Okay, good evening, dear doctors. Let's go and start the session. This is your mentor, Dr. Sharia. We have neurology class 02, I think. Yes. Okay. I hope so. Though the one that is, first one we take, it's fine actually, doing well. Recording thing, probably it will be posted a little much later actually. All right. Let's go and start it and the session actually. You're here for live classes, not recording, right? I mean, at the beginning of the classes, make sure this things doesn't come up. Yes. All right. All right. So I think today's coming up topic, if we just highlight in a second, it's like moreover like a stroke and some of the relevant thing, right? So for the stroke, I mean, what are the topic came in your mind when I say the term stroke, guys? Actually, I mean, regarding the MC, I'm going to tell you some of the important points regarding that. Whatever things you have seen, I mean, stroke in general, okay, ischemic stroke, hemorrhagic stroke, this can be some of the keywords for searching, right? If you search in the guideline group, this can be some of the keyword for searching. Correct? So here we go. I mean, about our neurology 02 to this class. And in neurology 02 class, we need to highlight some of the important topics. To this topic, there are a few things about the anatomical things would be there. That's very, very important. I think last day, I think it's here already. I'm regarding our outline. Let me show you the outline actually one more time. Great. So first of all, whatever we have done so far in the day one, we have done this particular topic. If you have missed that one, I mean, these are the pages. Okay, then we have came across another one with bacterial. So one was a viral, this one was bacterial, and one was a central nervous system infection. Okay, in John Murtagh 194, that was related to central nervous system, and these were those particular topics actually. Okay, great. Apart from that one, I mean, we came across and get to know about neurological dilemma, and which includes a long list of topics, including the upper motor, lower motor, and mixed up motor neuron disease, then dementia, then demyelinating, then four of the other things like PN, GBS, like Charcot-Marie, myasthenia gravis, this particular thing. Then there was a followed by thing, which was a headache, right? I mean, there was a headache thing and also dementia-related things. Okay, so those particular things, we have discussed. This one maybe you guys can have a look as a extra slide. One time it came up actually, lateral sign actually, just like has an association with multiple sclerosis, which we did last actually. Is a problem related to gait, motor problem, sensory problem, sexual problem, multi-system problem, and visual problem with the multiple sclerosis, which can be interrelated with this particular condition. This is like, I think, few months back it came up. It's as a bit new topic actually. That's the thing. Great. Next thing that is coming. Let's go and see. Okay. Let's go and see further things. Headache chapter. We have already done the headache chapter. Okay, one more thing I think regarding the headache, this is also included. I mean, the trigeminal neuralgia. Maybe I forget to mention that actually, because it was, a little bit, we have to go a little fast at the end actually. But anyways, we discussed some of the primary ones, and there's a one giant cell arteritis we discussed, and some of the causes I mentioned about the secondary. Right. So this is the trigeminal neuralgia, and regarding the trigeminal neuralgia, these are some of the particular topics regarding the trigeminal neuralgia. So basically it's related to the problem related to trigeminal nerve. Anywhere in the trigeminal distribution, there will be a trigger factor like touching, shaving, Okay, so and it will be a severe pain. A famous actor even had trigeminal neuralgia. I'm sure you know, like the Bollywood actor Salman Khan. So he was suffering from, trigeminal neuralgia at some point. If you have seen our notes, maybe you have seen that one as well. Okay, so that is the thing. So there would be like a over 50-year person, female, or even a man, okay, stab pain in the left mandible. Pain lasts for few seconds. So whenever there's a trigger, then there's a severe pain triggered by brushing of the teeth, chewing of the food, and few seconds, occurs 20 times per day. So your quality of life becomes quite a troublesome. Correct? She denies any recent trauma or dental procedure. Thinking that any dental issue, dental abscess can be the reason or not. She tried ibuprofen, but it's not happening. On examination, touching the mandibular region of face eliciting the pain actually. Neurological examination is unremarkable actually, so nothing much on the neurological examination. So this is mainly looks like a trigeminal neuralgia actually. Okay, so this is mainly the trigeminal neuralgia actually. That's one of the main things. So if you guys can go and check, we do have a trigeminal neuralgia full note on the medicine neurology, trigeminal neuralgia. Have a look on that one actually. Okay, you'll find it in medicine neuro trigeminal neuralgia actually. Okay, if anyone has finished that one, you must be knowing what is the treatment is mentioned in that full note. Any guesses, guys? Of course, when there is a pain, you need to give a painkiller, first of all. Wherever there is a pain, you need to give a painkiller. But other than that, definitely, is there's provision of steroid, that's fine. But we also look forward to things like, yeah, gabapentin. How about using gabapentin? Because sometimes the pain becomes too much troublesome. So carbamazepine, gabapentin, like a neurological analgesics actually. So those will be very much useful. Okay. In that particular slide, there was also mentioned about if the drug medical, and there was another thing mentioned as a surgical. I remember that. So what was that additional thing is mentioned in the surgical side? Nerve compression is a in general term, but there was a something. So this is the test of your advanced study. Let's see, who come up with that particular, term. Actually, I'm looking for. The concept is correct. The nerve decompression. Actually, does it has any name? Is that having any name? Nerve decompression is fine, but that also has a name actually. Okay, and also there's some radiation procedure actually. I also want to know about that. Ablation, some sort of ablation. Yes. Right. So have you also heard about the time gamma, like knife radiation actually? There's another term, the gamma knife radiation actually. So that one you can additionally also remember. And eventually nerve compression, and that will be a good idea. Anyways, you can just check that note. It's a easy peasy thing actually. Regarding the trigeminal neuralgia, this is the topic we are going to discuss today. In general, neuroanatomy, upper motor, lower motor neuron, stroke, TIA, bells, and so as the other thing I'm holding here for a few seconds. Okay, if you want to open John Muttak 1362, but we will open the note first actually. Great. So you do have a note on regarding this. It was mentioned as a stroke actually. So let's go and open that one actually initially. All right. Great. So let's take a few seconds to open up. Okay. Yes, we are ready. Okay. Loud and clear, guys. Can we move forward? Yes. Okay. So this is how it looks like initially. We don't want to go into too much basic about the stroke. I think I'm sure all of us deal with this stroke actually. It's an epidemiology of the stroke. Is it the third most common? This percent of people died. For MC, we might not need this kind of stat. It's for you actually. Yes. So you can see one thing. It is characterized by we used to hate the definitions, right? But these definitions, if you see deep down, it's actually useful. Acute stroke is characterized by rapid appearance of a focal deficit of the brain. Now, do you understand the term by when I say what is focal deficit of the brain? So, focal deficit of the brain, any particular area, say parietal having a cut down of blood supply. Okay, that particular area has some function which I will teach you today. So that particular area has some function. That particular function will be lost. Is it clear, everyone? Even I haven't mentioned about the what are the lobe function, but imagine there's a frontal lobe which is related to personality. Parietal has a intellectual function, motor things, then the temporal, then the occipital has the visual. So any of those particular or a combined, if it affected. So those particular area has functional centers will be also damaged, and eventually there will be deficit of the brain function. So are we clear about the definition? That what they do mean by the focal deficit of the brain function? Most commonly a hemiplegia. And when you have deficit of that particular area, so eventually the motor function is going to affect it actually, right? Motor function, your speech. Remember, speech is somewhere related to our four lobes actually. There's a fiber called arcus fiber, which is interconnected with all the lobes technically. So any lobe technically affected, your speech somehow get affected. That's why in every sort of stroke, is slurring of speech is it a common feature? Guys, stroke can be anywhere, here, anywhere. But the one side deviated, and that particular slurring of speech is one of the major is because the speech center is almost interrelated with all the lobes function. Okay, and it is also used as an emergency sign, like call 911 or call 000. For Australia, call 000, right? That's emergency. Most commonly a hemiplegia with or without signs of focal higher cerebral function, like you see. Most commonly a hemiplegia with or without sign of focal higher cerebral function, such as aphasia, eventually speech and this thing happening, hemisensory loss, visual field different, and brain stem related different. Brain stem has a lot of cranial nerves as well actually. So if it's a big portion is affected, some of the cranial nerve is also going to be affected, right? It's a possibility. So that's why this definition is a bit complex. When we used to be a student, we used to hate this type of definition, but now if you see, these are kind of like a criteria for a stroke. Am I right, guys? Like these particular things are kind of like a criteria for a stroke, like focal deficit of brain function with associated plus minus hemiplegia, sensory loss, visual field loss, and the brain stem, the cranial nerve related deficiencies. Right? Interesting. Right. And the simple definition, I remember I memorized this one. When I was in MBBS, I memorized this one. That one was in Davidson, I think. This one was in Davidson as far as I remember. And this one was a, somehow I find it, neurological impairment caused by disruption of the blood supply to a region of the brain. So that I understood easily actually. Okay, so anyways. Now, by stroke, you understand that mainly ischemic and the hemorrhagic stroke. I'd like to add something interesting before we get into the main thing. You all must be agreed aspirin and clopidogrel are the lifesaver drugs, or we can say the reduced mortality. Agreed, guys? Like if I ask you to name some drugs, those prevent mortality, these two drug name will be there always, right? Like aspirin, clopidogrel, or yes. So the question is, the aspirin one is recommended. Of course, we do check into a scoring system. Do you know which system I'm talking about? Which is scoring I'm talking about? Like if it is score 0 or 1, we like to go for giving an aspirin, and that is the CHAT scoring actually, or CHATS 2 or CHATS pass. Nowadays it is called CHATS pass. It's giving, still we use the word CHATS 2. Okay. Anyways, so according to CHAT score, I mean, if it is there, you introduce the aspirin, and there is a ischemic stroke. So fine, it will reduce the chance. Agreed, guys? Like you use it in ischemic stroke, eventually it will reduce the chance of further stroke or further thromboembolic chances. Now, why there is so many trial and research on that? Is it also possible that when you use the aspirin, it also increases the chance of hemorrhagic stroke, like a 15%, like somewhere I read? Okay, so that's another thing actually. So you try to prevent something, and then there's a chance of increasing something. Okay, that can be wrong. I mean, that 15% one, please do check how much it increases the chances of hemorrhagic stroke. That one, it can be less, I think, Okay, so it is very important now, even in spite of having CT. So nowadays, what they do is called a risk benefit ratio. So that's on that particular doctor or a professor or the patient background histories and this that. Okay, like taking that risk with aspirin definitely going to reduce the chance of ischemic, but increasing the chance of the hemorrhagic. Are you ready to take that chance actually? So that's on the doctor and the patient's history actually. It is increasing. A lot of research is going on that. Okay, but for a very long time, aspirin being randomly used. Have you seen, like, when we were becoming the doctor, or those of you who are practicing in for a while, have you seen, like, if you go like a 10 years back, 10 12 years back, aspirin was there almost in every prescription. Even if you are not doctor that time, you must have heard that someone is taking ecosprin. You heard this thing, I'm sure. But nowadays if you see, randomly this amount of ecosprin people are not taking as like before. Previously I used to find this ecosprin in everyone, like my grandparent or any other, that because even we didn't get into the MBBS. So okay, can you pass me that particular drug? Which one? Ecosprin. Yeah. So we remembered that actually. It was a invariable drug actually. So Ecosprin. Even though there was no stroke, even though there was no stroke happen, but there was Ecosprin was there actually. Even though there was no arrhythmia was there, but there was the Ecosprin. So if you don't have anything and if you don't follow the chats, there is no point of using the Ecosprin according to the new guidelines actually. Like it will increase also the chances of gastritic and bleeding peptidic. So do you agree also on that? If the person is not under the chats or that kind of risk factor, there is no point of using the Ecosprin anymore. Clear? I hope yes, actually. We'll open inquiry zone. You can also pass me if you know more latest updates on that. You can pass me, because some of the guidelines keep changing all the time. I'm telling you this thing right now, but next year, which I will be teaching a group of doctor, the whole thing can be changed immediately. Anyways, now about the stroke, the ischemic stroke and the hemorrhagic stroke, these two we know actually, and how it looks in CT scan. I hope so. We also know it actually. So hemorrhagic, this is hemorrhagic. It will look like white, right? And the ischemic looks like the black. That's the thing. Right? So hemorrhagic stroke and the ischemic stroke. There's some lacunar, smaller stroke. So don't ignore if you think and suspect someone is having a stroke, someone's family history of a stroke. Don't ignore, because there can be lacunar stroke to small vessel. Stroke can be there actually. And the bigger version like huge size, or like a frog is sitting in between, right? Something like that. So that is like a subarachnoid hemorrhage. Or in the sides, like a convex shape or semilunar shape. It can be extradural or the subdural hematoma, right? Those are also the strokes actually. Extradural and the subdural hematomas actually. Those are also the strokes actually. Okay. Coming to the types of stroke, you all must be doing TIA in 24 hours. If it is becoming fine. Someone was suspected. There was, changes in the face, changes in the hemiplegia or paresis, whatever it is. But as long as in the hospital, they are recovering very fast. That's a very typical TIA. Okay. Uh, STI is kind of like an earthquake. Earthquake policy. Earthquake normally, when an earthquake happens, that earthquake is more dangerous, or you are thinking there can be another next one. Okay. So the another one, you know we all are remaining, in high alert for the earthquake, actually aftershock, right? That term is called, I think, the aftershock. So same thing is kind of like here. Once someone is having this type of situation like TIA, arrhythmia, and all these things, there's a huge chance that they can again have, or even sooner, they can have a issue like that. Same goes with the subarachnoid hemorrhage. Again, any strokes, actually another blow can be there always. Okay. So TIA, stroke improper, the typical one, lasts more than 24 hours, and one, the condition deteriorating. This is one of the reason after a stroke immediately people are dead, actually. Stroke in evaluation, actually. Anyways, main thing, there's a cutting of the blood supply of that particular reason. I'm going to show you the particular things, actually. The source can be anything, can be atrial fibrillation, can be a drug, can be a recent surgery, can be anything, actually. Even a carotid stenosis, heart issues, or any DVT issues, or any family histories. All these things are very, very important. Now, coming to this point, are these particular things are familiar to you, or do you want me to explain these things like middle cerebral artery stroke, anterior cerebral artery stroke, posterior cerebral artery stroke? Are you guys familiar with these terms, actually? Okay, let me see the group chat. All right. Okay. Now, if you write yes, I will not understand. Like, do you understand it already, or you want me to explain? If you want me to explain that one in details, then please mention it as a explain. Okay. All right. Actually, if you say yes, I was thinking, okay. I mean, we did have a big group, like, very expert on neuro looks like, actually. Okay. Now, some people might know it. It's very good if anyone has read USMLE books in past, or so nowadays doctors are very smart, actually. But and nowadays, what I also found, people are looking for too much shortcut as well, actually, which is not actually. All right. Yeah. Yeah. There's a USMLE has a nice book called First Aid, actually. So that's also quite a nice lot of things, actually. Yeah. Kaplan series, and everything is just given in a first aid book. So the USMLE step 1, step 2, the first aid series books are very nice. A lot of slide. If you see, I also took sometimes, actually, from. Yeah. So anyways, coming from that one. Yeah. First of all, it is mentioned as a middle cerebral artery. Then comes anterior cerebral artery. Okay, there's an line mentioned, leg more than arm. Weakness. Why? Okay, we'll come back to there. Posterior cerebral artery. There's some few points been mentioned. Now, certainly, if I see like that, it looks a little difficult to me, right? So for that one, I have to, we'll come back to here. Yeah, so see, act first, actually. So let's find out few things about the neuroanatomy. So we'll come back to that particular slide after a little going through the anatomical section, actually. Step by step, if we go, it will be easy. Let's not rush here. This part is sensitive. Do not leave the classroom now, actually. And we are fresh in the beginning, so please, I want all of you to fully focus. This is a hemi section, right? So I'm sure all of you are familiar with the cortex, then cerebellum, ventricles, pituitary glands, and here's the brain stem, midbrain, pons, medulla, and all these things. This is a picture of what? This is a picture of homunculus. Okay, some of you might forget about it. Some of you, those are in practice, they know about it. Homunculus, actually. Homunculus, anyways. Now, you see this, it is drawn in that way. This is the midline. This is the midline, and this is the lateral side. So from the medial side towards lateral side, leg comes first, then come hand, then face, and so as the other thing. So the theory is here, if this particular part which I'm trying to highlight, I hope so you can see the arrow. In that case, if only this particular part affected, what do you think? That leg will be more affected or arm will be more affected? The part I'm trying to show you right now. What do you think? Which part? So leg will be more affected. Okay, leg will be more affected. If this particular part, this medial part, I would say the medial part is more affected, or midline part or medial part, then leg is more affected than the arm. Okay, you got this concept? Please write it down. Actually, we'll also use this concept at some point. Actually, we'll also use this concept at some point. So this medial part more related to leg. I'll explain it later. Okay, same thing, another homunculus picture. The medial part has more related to the legs. Now coming to this particular part, another view of the brain actually. Okay, are you familiar with the term, this particular sulcus? Okay, the main sulcus is this one. In front and just behind actually. Okay. Premotor area. This is another one. So this is a motor area. This is a premotor. This is a motor area. The blue is a sensory area. This is a central sulcus, main sulcus. Okay, little bit coming. I think if even if you forget some of that neuroanatomy, I hope it's coming back little bit. So this is the main one, central. Okay, demarcation. In front of that one is a motor one. I hope all of you remember that. Before that is that sensory one. So they have highlighted in a red or blue. And now you see, if you imagine this view, okay, this is the medial part, this is the lateral part. So from medial part, was it the foot was there or the hand was there actually? Now it's your turn. Now in that most medial part, leg or feet was there actually. Okay, so leg, feet, and then comes the hand, face. Yeah. So this is that view. Now all we need is the blood supply mapping actually. If the blood supply is affecting this, which part is affecting, we actually can detect actually. That's why it is often called the neurosurgeon call that, this is more like a map. Have you ever heard about this kind of term? That often the neurosurgeon or neurologist, they're telling that neuro, especially these particular things, are more like maths actually. Okay, it's actually detectable, like where is the lesion. Even sometimes with the CT scan, I mean, very good expert clinicians actually can tell like where is the site of the lesion. Now here is another area of distribution. This is the central sulcus, motor area, sensory area, visual area, auditory area, Broca's motor speech area. Okay, and last but not the least, Wernicke's area. So these are some of the particular functional areas. Okay, I'm trying to go with the major basics actually in easy way. Let me highlight again: central sulcus, motor area, sensory area, Broca's motor speech area. This is that temporal area, auditory, Wernicke's area, visual area. Clear, everyone? Shall we move to the next slide? Yes, it is. Okay. Next coming is a cerebral circulation. In general, it is looking a little bit, it's a circle of Puttis. So some of the major arteries conjoined by some communicating arteries. So anterior communicating artery, posterior communicating artery, connecting the anterior cerebral arteries. Posterior, these things is also connecting some of the arteries actually. So circle of Willis, just have a look one time. And here is a picture. And so middle cerebral artery, blood supply. You can see, can I say like that, that middle cerebral artery kind of like supplies the lateral surface? Can you see that? This is the lateral part, right? Outside the brain. So middle cerebral artery kind of like supplies the lateral surface, the bigger portion of the brain. Now, if you remember, in this particular area, Broca's area, temporal area, many of these things centers were there. That means those particular things, including the speech, motor, all these things would be affected. Right? Now, this is the main heart. Whatever I was trying to show, this is the main one. I'm holding here a few seconds. Try to understand the color. I believe no one here is a color blind. I mean, and a little bit alert to our female doctors that what is my understanding by telling this is hopefully I'm right. This is red, and this one is what color? Cream color, and this one is pink color actually. So please pardon me if I'm okay with the color actually with you actually, because if you ask any female about colors actually they will tell you red as a 10 different color actually. Okay, so I just want to be sure that this is red, this is kind of like cream color. Okay, now it started someone baby pink. Okay, guys, let's not get lost actually shortly. What is baby pink? I have no idea first of all. What is peach? Oh, okay, peach color. Okay, this one you mean peach color. Okay. Okay, I don't want to see the messenger box now. I'll be lost very soon, I think. Okay, let's follow whatever I say actually about the color. This is red. Let's go with the last one as a pink, and the middle one, what should I take as a peach? So last one is peach. I'm very sorry. Okay, this is peach. Now this is. Okay, now I think like a pseudo stroke I'm going to have actually looks like actually. So this is actually. Yeah. Okay, peach color. Okay, thank you for correcting me. Okay. Red, peach, and how about the middle one? No, we supposed to do that actually. Okay. Never knew even there is a color. Guys, I need some of your help. Have you ever heard about baby pink color actually? Okay. If not, now you see actually. No, that one is for the guys actually. Yes. Okay. All right. So red, baby pink, and peach. Okay, I will go with our audience today actually. Okay, but if I get lost in between, please help me. God help me. Okay. What I was saying. Okay. All right. Let's come and let's focus. This is the lateral surface. This is the lateral surface. This is the medial surface, and this is you can see the inferior view. Yes, this is the inferior view. Okay, something very important I learned today. Okay, like I learned about baby pink. I learned about the pitch. Wonderful day looks like. Okay, let's come and focus for a while. Fun apart fun is on another side. Now this particular color, which some people saying baby pink. This one, do you think which particular artery, which is covering a very big major portion? Covering a very big major portion actually. Okay, so this baby pink color is a middle cerebral artery covering a major portion, including you see Broca's area, temporal area, Wernicke's area, all they are covering. But are they covering the occipital area by any chance? Quick question. Are they covering the occipital or the visual area by any chance? The answer is a no. Are they covering the frontal lobe by any chance? Which is related to your personality. Answer is also no. Frontal lobe is here somewhere. It is also not covering it. Are they covering the medial surface? Are they covering the medial surface? This one is a medial view. The midline and the middle view. It is also not covering it technically in that way. Okay. So this one is the lateral surface, and lateral surface not all the lateral. So we can say the first 2 centimeter. So initial 2 centimeter. It is also not covering. No. Can I add in that way that middle cerebral artery has less dominant over the leg area? think logically. Middle cerebral artery. This area is for foot and leg. Foot and leg. Is it less effect on the foot and the leg? Agreed, guys? So that particular part related to which particular artery? Like leg will be more affected in which artery, which has a red one. That is the anterior cerebral artery. So anterior cerebral artery stroke, can we say, like all these cases will have some motor issues, right? That is common. All these cases we have some motor issues, slurring of speech, but we have to check which part is more affected. If leg is more affected than the arm, leg more affected than the arm, then it is anterior cerebral artery. Clear this one? If leg more affected than the arm, in case of motor, anterior cerebral artery. In that case. Okay, so this is a big clue in terms of even without CT scan. Now you can proceed with a lot of things. Actually, you can literally get idea by seeing the patient. Okay, and this is the medial surface. You see the anterior cerebral artery supplying the whole this medial part as well. Yeah, whole this medial part actually. All right. So this particular area is a middle cerebral artery. That particular area is a anterior cerebral artery. Anterior cerebral artery. And since previously I have shown the picture of homunculus, now you come here. This is the part of the homunculus. Imagine from here to here, supplied by the here to here, supplied by the middle cerebral artery. So this will be more predominant on the hands, face, and it will be less dominant on the leg. Whereas anterior cerebral artery is supplying this portion, the medial portion. So this is more predominant on the leg. Now it is clear? I hope it is clear. It's supposed to be clear. Okay. This is the predominant part for the anterior cerebral artery. This part is for the middle cerebral artery. So that's why this is we are calling the leg part. This is we are calling the hand and face part. Okay. There may be a little new concept, but I think you will be fine when you practice and discuss with a friend. This is why important. The difficult topics I always highly recommend discuss with your friend. Actually, something will come up actually. And do you understand this? The last one, the pitch color. The pitch color eventually affecting the occipital lobe and the posterior part of the brain, and that is somewhere related to visual area. Right? Our visual area is here. Yeah. So this one is easy. Okay. Now, if we go back to our that previous where we left, I told you that I will come back here. So let's see with this one first actually. Anterior cerebral artery. So anterior cerebral artery is like the medial part, also the frontal part, medial and the frontal part. So technically can I say that since it is covering the frontal part, the frontal lobe is related to your personality. So your personality can be affected with anterior cerebral artery. Everyone agreed? Yes. Right. So frontal part and the medial part. So this is the So frontal is related to personality. It will be affected. Okay. I will show you a mnemonic now actually about the frontal lobe. Now it's my duty to guide you on these things. Frontal lobe. I have a mnemonic called PES mass. Now what does it mean? P equals to personality. You guys can also appreciate here by commenting. E for what? E for emotion. Okay. Now you need to ask this opinion. Not only like say suddenly wife is coming and telling that his husband is no longer showing any emotion. Do you think it can be neurological, or there can be more other differentials? What do you think? No, it should not be only wife. It should be wife, other family members, neighbors. Many people are telling, and your judgment actually. Okay, so anyway, so fun apart. that telling that you are changed or something like that. So anyways, P for personality, E for emotion, S for social behavior. So you need to also check the social behavior and not only the emotion. Emotionally people changed all the time, right? Mass, very important. Motor control. Motor control. U for urination. A for urination. And S for what? Lastly, S for speech. Speech is universal. It is related to all the four lobes actually. Okay, great. Everyone, is it fine, guys? All right. So it is base mass and everything good. Base and mass and everything good. Now, coming to that particular last slide, if you see now, from where this urinary incontinence coming up suddenly? Because it is related to frontal lobe, and frontal lobe is related to. So we also add more points? More points like what? More points like we can also write um, less emotion, less emotion, motor control would be less, right? And motor control already mentioned here, and leg is more than the arm. Okay, is all the points are like matching, guys? And also, what do you think? Speech is affected? Yes, speech will be affected too. Speech also will be affected. Okay, clear now, everyone? So they mentioned like two, three, but we can mention even more. Is it clear, everyone, now? Why personality is here? Because of frontal lobe. Urinary incontinence because of that mnemonic I just taught, pace mass. And speech is universal. Speech is universal. And very, very importantly, this particular line, why leg is more than the arm, is because of the homunculus. All good? Is because of the homunculus with anterior cerebral artery. Now coming to the next one is a big one, which is the middle cerebral artery, right? And do you agree middle cerebral artery supplies the major part of the brain? Do you agree on this point? The major part of the brain, except for the frontal area, except for the medial area, except for the frontal, except for the medial, except for the below that occipital. Otherwise, it is supplying almost everything. Can I also add few terms like a Broca's speech area, Wernicke's area? These areas are also affected in middle cerebral artery. What do you think? Let me show you. Just want to show you again. Yes. So this auditory area, Broca's area, Wernicke's area. So this is the supply area of the middle cerebral artery. Correct? So Broca's area, temporal area, Wernicke's area, almost Wernicke also I think affected here. Like it should be like that. Is all our area. Yes, I mean that baby pink area. Thanks for reminding. I'll not forget this color now. That's why discussions are important. I'm taking very something important from this class today. Okay. Anyways, so I mentioned one thing. I mean, no matter what sort of stroke is that, you will have the weakness and there will be loss of motor control. Okay, everyone agree? Middle cerebral artery, guys. Come on, definitely there will be motor control, hemiplegia or hemiparesis. All right. All right. My internet, I think my internet is fine. I think. You don't need to do anything. If internet is a problem, there will be a message will come up actually. You check your own internet, my dear. I think, I guess. If my one would be troublesome, I will understand immediately. Everyone will be messaging then. Okay, always check with a friend first before messaging. Yes. No, it's fine. We know it.
Yes. Okay.
Yes. Okay.
I mean, we do have a
Notification. Once internet unstable, we get a notification. Some people also don't use mic. Some people are using tablets. See, one thing do understand. In future, when you take the mock test, please make sure do not use any mobile or any tab. Even during classes, when you come, when you use a tab, when you use a mobile and this that, because the classes are designed for the Zoom, only Zoom, and it's more for the laptop actually. Even if you go to the MC Part 2 exam, it is all like laptop based, so that's one of the thing. Windows system. Even MC Part 1, when you go, it's again the Windows, and otherwise they would all have tablets and this that. So a lot of function you might not get and thing happen if you are using the mobile and the tablets actually, and also there will be distractor at the same time. Okay, let's come back and focus. Middle cerebral artery, which is that baby pink one. Motor control would be affected. Can I also say sensory control would be affected? Now let me show you that picture. How come sensory control is also affected? So here is that sensory area. So technically, you see, sensory also affected. Everyone agreed? Sensory area also affected. Okay. So weakness on sensory loss, contralateral side. Okay. It is affected. Okay. One another basic for all the cerebral area. Cerebral area, because of track crossing, eventually it is usually we use the word contralateral. That means the main lesion is probably in the opposite side. Are you familiar with this term? Cerebral cortex area, the lesion is in the opposite side. What about the cerebellum? What about cerebellum? Is it in cerebellum same side or is it like the opposite side? For cerebellum, it's same side, ipsilateral side. Okay, same side, ipsilateral side. For cerebral cortex, which we are talking about right now, that is the opposite or contralateral. So this is another term would be contralateral. Contralateral. That has a very big, long explanation in neuroanatomy. Actually, if you remember at least this, it would be easy for you to do the calculation. Okay. Now, next another thing which is mentioned, which is somewhere related to the visual field, there would be homonymous hemianopia. Okay, there will be homonymous hemianopia actually, which will come at the end of the class as well. So homonymous hemianopia is. Do you remember homonymous hemianopia? Like our eye has fields like that. Our eyes has a fields like that. So homonymous hemianopia. Okay, I'll explain it later actually. For now, just remember it actually. Visual field would be lost actually. Right-sided visual dose field would be lost. Okay, and aphasia. Did I mention that speech would be affected in almost in all lobes? Speech would be because of the arcus fiber. Icus fiber is connected in between all the lobes, so with the speech center, so aphasia. Okay. Is it clear now, everyone? So what happens in the middle cerebral artery? So motor would be affected, and we can also add, which is they don't mention it, but we can also add auditory will be also affected. What do you think? Because the primary auditory area is also coming under this. So they didn't mention, but we know that auditory is also going to be affected with the middle cerebral artery. Actually, if that particular center is hit, your auditory can be also affected. Right? Clear now, everyone? Motor, auditory, yeah, and also this visual, homonymous hemianopia, and the speech. Clear, everyone? This is the most difficult portion we are going through. Okay, if you cover up this, you will be in great shape. Last section. This one is the easy one. Can we mention like even posterior cerebral artery, but your motor will be still can be affected? Do you agree on that one? That it is a possibility that the motor can be affected no matter any place, So that's limb ataxia is because of the motor. Did I also mention speech can be affected no matter wherever it is? Speech can be affected. So speech at the speech, at the motor. And limb ataxia is nothing but the motor. Sensory is almost always there. So sensory, contralateral sensory loss, contralateral because we are in the cerebral cortex. Since we are in the cerebral cortex, that's why it is always opposite. So opposite, like contralateral sensory loss, original relation. Alright. So that's the thing. But about the brain stem again, cerebellum and the brain stem. This particular area are the ipsilateral, right, guys? So brain stem, cerebellum, this particular areas are so ipsilateral sensory lobe of the face, ninth and the 10th. Clear now, guys? Why it is mentioned like ninth and 10th, same side, because that's in the brain stem, not in the cortex. Is this clear to all of our doctors? So that's the part in the brain stem, and that's cerebellar area. That because it's in the same side. Whereas the contralateral is the sensory and limb ataxia. Okay, very difficult, but you need to discuss it very soon with your study partner. Otherwise, all the discussions you will forget. Okay, I hope you enjoyed the discussion. Now it's a test for you. Middle cerebral artery occlusion. There is. This is a test of your whatever you have learned. Testing and MCQ, yes. They mention weakness of the. Initially, it sounds this one is the answer. Is this your answer? Is it possible? Is it leg? Striking your mind. No. It's the hand, feet, those things. Okay, that's how you can remove that one. Aphasia. Inflation is right. Anyway, that's like it's middle cerebral occlusion, so we're not going with this. Hemianosmia is not like this one. Contralateral noun is not going like perineum. So not perineum. That's like another thing that is out. There's a contralateral hemiplasia. So motor control loss. Control loss. Which side? Opposite side. So I think this one is matching the most. This one is the correct answer. Clear everyone? All good? Yes. Okay, well done. Okay. So here is the things. You guys did well, I believe. Did I mention in the endocrine about the main association, guys? Did I mention about the main association? If someone missed it, here is another slide of the main association. Actually, this note is already there in our note section. You can have a revision on that one. Okay. These are the basic parts actually. But I have seen this because everyone struggle with that question with the which artery. So they often love to add that question actually. Alright. Now this thing is coming is the lobe function. Already one we mentioned is a frontal lobe and the pes mass. Do I need to explain again the pes mass? I think we are fine actually. Okay. Do I need to again tell about pes mass? So let's go to the parietal lobe then actually. Pes mass we already know all these things. Now parietal lobe, dominant and non-dominant. Parietal lobe's main function is one of the your intellectual like or the intellectual skills actually, like a calculation, constructional speaking, all
All
these
these
things.
things.
And
And
language is
language is
universal.
universal.
Everywhere I
Everywhere I
go,
go,
this
this
language
language
is
is
universal.
universal.
So this your constructional skill or calculation, this will be affected in this case. Correct? Okay. Next coming is a temporal lobe. Temporal means auditory. Everyone knows that auditory. Speech is universal. Speech is there. Okay. Speech or verbal. Is also smell can be also there. So dominant, non-dominant, almost it's kind of the similar actually. Only exception is this particular point, dominant, nominant, verbal, non-verbal, nothing much. Interesting thing, melody is related to auditory actually. Okay. Guys, do you remember the Walkman days? You know, there used to be Walkman phone, Walkman series. We have gone through, I think, even AirPod at some point. So how much things are changing? I still like, rather than listening the music into the mobile, I prefer a separate device for the music actually, because mobile is a huge distractor. Believe me or not, even the see what is the motive of iPod? In iPod there will be Wi-Fi, correct? And if it is a Wi-Fi, even nowadays the iPod has even chat option. Everything seems is quite big nowadays. So they don't want you to uh, stop anything. They want you to stay active and check their marketing things, what they try to sell. They do try to do research on you all the time actually. Okay, so those are the things. So very interestingly, when I came back this time, from UK, I went to a museum. Walkman they put into the museum. So I was feeling, am I become very old now actually? They put the Walkman into the museum actually. CD player also into the museum. Walkman, CD player, DVD player, all these things actually. Anyways, I think the next generation will find it as, yeah. Now I searched in Amazon and I found a like Walkman, the typical, the Walkman and yeah. So typical a Walkman. I mean, because some people like the retro things actually. For me it was like a bit retro. Secondly, it looks like a bit soothing. Like your cassette is moving. You are looking at it rather than you are watching at the same time listening a music, and there is another Facebook video, disturbing Facebook video is coming in front of you, right? Rather than you have a Walkman where the cassette is rolling, something like that. So I brought that the Walkman and some blank cassettes actually. I'll see and if I can put some recording again actually. Anyways, as fun apart, you can always do those kind of things actually. But it's interesting. It's always interesting actually. Okay. Last but not the least, it is. But just for information, if you are into retro things, that's available in those like Amazon things actually as a like a Walkman. Walkman. But someone mentioned that one. There is a audio. I mean, Android version. I mean, it looks like Walkman, but you have to put a memory card actually. So I don't want that actually. I want that cassette player rolling with the those tapes. You know. All right. And there is another sound when it's like going on. Anyways, occipital lobe is related to visual. Are you all familiar now with the lobe function, guys? Frontal, pesimus, parietal, your constructual skill. Temporal is like auditory melody, and occipital is visual. Speech is universal. All good? Yes, I think. Yes. Now here is another version of this thing. Middle cerebral artery, anterior cerebral artery. Those all things. The same thing is mentioned, like a contralateral paralysis, contralateral hemiplegia, contralateral hemiplegia. Just now we solved an MCQ. Contralateral sensory loss on the face and this thing, because it is in the cerebral cortex actually. Yeah. So just have a look on that one. here you need to focus on one more. If most difficult question will be made in MC, will be from this particular section actually. So other than the middle cerebral artery, anterocerebral artery, and posterior cerebral artery, additionally you need to learn this one, pica. Okay, which is the lateral medullary syndrome actually. Okay. Did you heard that about this term to come in MC exam? This is actually very important. Like lateral medullary syndrome or pica, posterior inferior cerebellar artery in occlusion actually, and it has some other particular point. This one I will explain separately actually. Okay, so for that one, let me take you to a cross section. Did I mention last day only one particular cross section I will teach you because that's important for MC, and this is that cross section is coming. It's not that difficult. Okay, then we'll be finishing with an MCQ actually. Just taking a second to bring it out. Okay, got it. Here we go. This one is not present in that note, which I'm showing from my additional slide. So this one, maybe you can take initially a picture first, actually. All right. I'm going to explain. So don't worry and don't get scared, actually. All right. First of all, this fish or prawn shaped, what is this thing is called? Maybe you all forget the neuroanatomy. Let's just trying to focus. Like, what is this particular thing is called? Can you be more specific? Like, see, cerebellum is a very big thing. Nucleus is okay. This particular. By any chance, can it be olive? Actually, the olivary nucleus or the olive. This particular thing. If you try to remember the olivary or olive, seeing this one, we understand the cross section actually. I mean, which area it belongs to actually. Like, is all the cross section contains olive? Answer is a no. Right. So that is the thing. Like seeing the olive, we do understand which area cross section it belongs to. Okay, we are coming to that point. We can go into that. Yeah, inferior olivary nucleus. Well done, my dear. Okay. Now it is also known as Wellenberg. Right? It is also another name is a Wellenberg, lateral medullary syndrome, and all this. So this is that how the cross section looks like. And we have highlighted few of the nucleuses. Now, first of all, what is this nucleuses are related to? This particular violet color, you can see nucleus. So nucleus ambiguous, nucleus solitarius, these particular things out there actually. Inferior cerebellar peduncle. Okay, so cerebellar is this side. This is peduncle, the little elevated peduncles actually. There's a very important in this particular section. This cranial nerve 5 nucleus is there. Okay. This red one, cranial nerve 5 nucleus. It belongs to. Other than that, nucleus ambiguous, nucleus solitarius, and this yellow one. Because it's not just a cross section, there will be fiber also going, right? Like some motor fiber in the behind, sensory fiber in the lateral side, some other fiber. Okay, so this is the fiber we can see actually, descending sympathetic fiber here. Now, if you see the right hand side of the table, all these nucleuses has some function. All these nucleuses are having some function. A quick question to ask to all of you, because this is a section related to brainstem. So most of the features will be
same side
ipsilateral or
very quick and
contralateral. Very
important.
quick and
Since it is
important.
related to the
Since it is
brainstem
related to the brainstem
or cerebellum,
or
this
cerebellum,
particular
this
areas,
particular areas,
most of the features
are
are
related to
same
the
side,
same
that
side,
is ipsilateral.
that is
That is the
ipsilateral.
reason.
That is the reason.
Your cerebellar
Your
peduncle
cerebellar
affected
peduncle
ataxia,
affected
same side.
ataxia, same side.
Vestibular and
Vestibule is related to our balance
vertigo.
vertigo. It's affected.
Facial
Ipsilateral
loss,
facial loss,
hoarseness,
hoarseness,
then
then
ipsilateral,
ipsilateral,
decreased
decreased
test,
test, ipsilateral
Horner syndrome.
Horner syndrome. Except for one, which one?
Green one.
The green one.
Green one is
The green one is a lateral spinothalamic tract. Remember one thing, I will teach the tract, which is our spinal cord related thing.
There are some motor
There
tract,
are some motor
sensory
tract,
tract, that is
sensory tract, and that is spinothalamic tract. That
spinothalamic
spinothalamic
tract
tract is the tract
where the
where
crossing
the
happens not
crossing
in the
happens not
olivary
in the
area.
olivary area.
Crossing happens
The crossing happens
below.
much down below.
Okay. The
Okay.
crossing happens
The crossing
much
happens
down
much
below,
down below actually for the
spinothalamic.
spinothalamic
That is the
tract.
reason.
That is the
There
reason
is a
there is a
contralateral,
contralateral,
in the
in
pain
the
and the temperature.
pain and the temperature. Spinothalamic tract is related to contralateral.
I remember as a
I remember as a patella.
pain,
Pain, temperature, lateral spinothalamic tract.
patella.
Patella.
Pain, temperature,
Lateral spinothalamic tract. Opposite side. So few of the things, if it's not much visible, you are not into neuroanatomy, few of the things you can use the formula and you can memorize it. Okay, so what to memorize here? Because it is in the brainstem or the cerebral particular area. So all these particular things would be ipsilateral except for spinothalamic tract, which is a crossing tract, and its crossing is much down below, which is the so contralateral pain and temperature. Is it clear, guys? Patella, yes. Is it clear? If not clear, at least memorize it actually. You can do it actually. And these are the features would be given. Now, in order to make sure that you understood or not, I have a question for you actually here. Okay? Because this is a 5-star question. So let's see this one actually. Okay. If my face is coming in front of the screen and obstructing it, you can swipe it in the side. A 59-year male presented to the 6-hour history of sudden diplopia, vertigo, nausea, vomiting, left-sided facial weakness, right-sided paresthesia. This that he has a past history of ischemic stroke, hyperlipidemia, hypertension. These are very common as a past history. When a person suffering from this thing, he's also on a lot of drugs. This is how your normal questions would be, I'm telling you. On examination, positive cerebellar signs, ipsilateral ptosis, right-sided facial loss, and temperature loss, and left-sided facial numbness. Right-sided loss of pain temperature, left-sided facial numbness. Now, from the last on examination, this part, you actually can guess, first of all, where is the site of lesion. It is our first job to rule out where is the site of lesion. Is it a right-sided or a left-sided? Because pain temperature in the right side, which is contralateral. The original thing would be in the left side. Because only this thing is contralateral. And left-sided facial. So it is always left-sided, even in case of face. We just know. So original lesion in the left side. And this is lateral medullary. All these features you see, is it matching with the nucleuses? Yes, it is matching with the nucleuses. This is lateral medullary syndrome. I'll open the neuro. Did I open the neuro inquiry zone, guys? Yet? Oh no. Okay. Why it is? Let me check. Inquiry zone. No, I think. Let me open it. Feel free to ask anything.
And someone remind me
And
to
someone remind
upload
me to upload
the difference
the
between
difference
medial
between medial
medullary
medullary
syndrome and
syndrome and
lateral
lateral
medullary
medullary
syndrome.
syndrome.
Okay,
Okay,
I'll
I'll try to
upload a table
upload a
so
table
that you can
so that
differentiate
you can
between them.
differentiate between them.
Okay, it will be easy
Okay,
for you.
it
I'll
will be
try
easy
to
for
put
you.
a
I'll
easy
try to
peasy
put
one
a
for you.
easy
I
peasy
don't
one
want
for
to
you.
bring
I
the
don't want to bring the
medullary now.
medullary now.
Whatever you understood,
Whatever
I
you
don't want to mess
understood, I
that
don't
one
want to
actually
mess
now.
that one
Rather than
actually
if I
now.
bring a
Rather than
table,
if
it
I
will be
bring a
easy.
table, it will be
Okay,
easy
all
for
good.
you. Okay, all good.
So medial
So
medullary syndrome
medial
and lateral
medullary
medullary
syndrome and
syndrome.
lateral
Lateral medullary
medullary syndrome.
syndrome
Lateral
is a
medullary
five star.
syndrome is a five
Nice
star.
to know is a
Nice to know
medial
is a
medullary
medial
syndrome
medullary
because
syndrome.
lateral
Because
medullary is
lateral
given. It
medullary is
means medial
given, it
medullary
means medial
can be
medullary
given.
can be given.
Clear everyone?
Clear
So
everyone? So
this is the
this is the
ICA
ICA
related to kind of
related
like
to
medial
kind of
medullary.
like
You can
medial
just have a
medullary.
look
You
on
can
that
just
one.
have a look on that one.
Okay, is it clear,
Okay,
guys?
is it
It was
clear,
looking
guys? It
little,
was looking little,
you know,
you know,
what should I
what
say?
should I
Hizzy
say?
busy.
Hizzy
Are
busy.
you familiar with this
Are you
term?
familiar with this
Hizzy
term?
busy.
Hizzy busy.
Okay, it's like
Okay,
a
it's like a little bit
confusing.
confusing.
Right. Now,
Right.
after that
Now,
particular
after that
slide,
particular slide,
yeah,
yeah,
this cross section,
this cross section,
yes,
yes, looks easy.
all right.
All right.
So this is a warning
So
sensor
there's a
given.
warning sensor given.
The like
The like
face affecting this
face
that you
affecting
can
this
read by
that you
yourself.
can read by
Risk
yourself.
factor for you. Do I
Risk
need to
factor for
teach
you.
risk
Do I
factor
need to
of a
teach
stroke?
risk factor of a
Modifiable,
stroke?
non-modifiable?
Modifiable, non-modifiable?
Guys,
Guys,
I mean,
I
I'm sure
mean,
this is a
I'm sure this is a
too much MBBS
too
topic.
much MBBS topic.
You can
You can
check it one time by
check it
yourself,
one
like
time by yourself,
modifiable,
like modifiable,
non-modifiable.
non-modifiable.
Nothing much here. I mean,
Nothing
this is
much here.
not even a
I mean, this is
question.
not even a
This
question.
is
This is
already
already
will be given as a
will
risk
be given
factor
as a risk
in your
factor
question. So
in your
just
question.
watch
So
it one
just
time.
watch it one time.
All right.
All right.
So this is how
So this
things are
is
given
how
actually.
things are given actually.
Mechanism you don't
Mechanism you don't need actually.
Okay.
Okay.
Investigations.
Investigations actually. Investigations regarding the
Neurology.
neurology.
Investigation
Investigation
regarding
regarding
the
the
neurology.
neurology. I mean, most of you must be
Do.
knowing what we do.
If there is a sign of
If
a
there is a
stroke,
sign
one
of a
basic
stroke,
thing,
one
what do you
basic
think?
thing, what do you
One
think?
basic test we
One
all do
basic test we
to
all
rule out.
do
What
to
is
rule
that?
out. What is
Without
that?
any further
Without
delay,
any
we
further
have
delay,
to
we
go,
have to
not
go.
love,
I mean, not love. I
mandatorily.
mean,
We want
mandatorily,
to go with the
we
CT
want to go
scan
with a
without any
CT scan
further
without
delay.
any further
Now
delay.
let me tell you one
Now, let me
interesting
tell you
thing.
one interesting thing.
In case of
Stroke cases,
after
after
CT
CT
scan,
scan,
if it is not fully
fully
clear,
clear,
let's say it's a
hemorrhagic
hemorrhagic
stroke,
stroke,
it's not fully
it's
clear,
not fully clear, and
and
you need a map
you
for
need
the
a map for the
neurosurgeons.
neurosurgeons.
I mean, just
I mean,
based
just
on the CT
based on
MRI,
the CT
the
MRI,
neurosurgeons
the
cannot proceed.
neurosurgeons cannot proceed.
Um, Even with
Um,
MRI
Even
cannot
with MRI cannot
proceed at all. So
be
you need the
proceeded always. You
exact
need the exact
roadmap
roadmap
before drilling and
before
opening the
drilling
brain.
and opening the brain.
And here comes
And
the,
here comes the,
cerebral
cerebral
angiography. You use a
angiography.
dye
You use a dye
to see
to
where the
see where the
uh, branches and which one
branches and
is
which
teared
one is
or which one
teared
is
or
leaking.
which one is
So
leaking.
you need the map.
So you need the map.
Okay, so cerebral
Okay, so
angiography.
cerebral
Is it clear,
angiography.
everyone?
Is it clear,
That
everyone?
we do the
That
basic
we do the
test,
basic
mainly CT
test,
scan,
mainly
this, that,
CT
and
scan, this, that,
if you
and
find the
if you
hemorrhagic or
find the
something,
hemorrhagic or
we need
something,
further
we need
mapping
further mapping
by doing a
by
cerebral
doing a
angiography.
cerebral
Okay,
angiography.
great.
Okay, great.
All good.
All
If
good.
you suspect
If you
anything
suspect
other, you
anything
can also go for
other, you can
lumbar
also go
puncture
for
and this,
lumbar
that.
puncture and this, that.
Okay, so too many
Okay,
things are
so too
given,
many
but
things are
just
given,
remember
but
this thing
just
actually.
remember this thing actually.
This question came
This
like a
question came like a
suspected stroke. What to
suspected
do? You
stroke.
go for
What
a
to do?
CT
Go
scan.
for a CT scan.
I want to add
I want
a
to add
extra
a
question here,
extra question
which is a
here, which is a
different one than the
different
stroke.
one than the
Actually,
stroke actually.
indication
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 of head
of
city.
head city.
Okay,
Okay,
especially in case of
especially
head
in case of
injury.
head injury.
Okay, separately,
Okay, separately,
like
like
if you fall down
if
from
you
a
fall
bike,
down from a bike,
is it like
is
always
it like
you are going to
always
do head
you are
CT
going to do
scan?
head CT scan?
Okay, this is a
Okay, this is a
okay. Someone
okay.
came
Someone came
after a fall
after
from a
a
bike.
fall from a bike.
He mentioned he
He
lost
mentioned he lost
uh,
consciousness for few seconds, then afterwards is fine.
Okay.
Okay.
Because
Initial impact
you can lose consciousness.
you can lose consciousness. Now
He came and
he came and
he said he had
vomited one time.
vomited one.
Vomited one time.
Is this an
Is this an indication of
PET CT scan?
PET CT scan?
Fall down?
Fall down? Just for few seconds he's bang. Anyone of us, even say example, if I'm taking class, if I fall down with chair, so for few seconds, that's not a deteriorating level of consciousness.
You understand the point?
You understand the point?
Deteriorating
level of consciousness is the indication.
But just
because fall down and one time, that's not the indication. Secondly, I mentioned vomiting. Okay, vomiting once. Is that a criteria? Someone mentioned, yeah, you can check the nexus criteria, or someone in the our inquiry zone later can post that nexus criteria. Okay, whoever mentioned, I mean, post that one so that others can see that one. Now, one time vomiting is not an indication. You can observe the person. Many head injuries or falling down, we actually observe actually. Vomiting more than vomiting, two or more than two. That's the indication. Vomiting, two or more than two. Clear now? After a head injury, vomiting two or more than two. Okay, that's the thing. I forgot. It's in my emergency medicine lecture. I mean, surgery class 3. Though, but it came up. Okay, I think that's the slide. Since it came up, that's why I'm telling it here. See, more than one episode of vomiting. That means two or more than two. So this is the indication of head city. Also deteriorating level of consciousness. What do you mean? You just fall down one time. That's not the thing we're looking for. If you're deteriorating level of consciousness, because means GCS. No, we are all understood by the GCS. If the GCS is falling, then it matters actually. Then if there's an open skull or depressed skull after the injury, post-traumatic fate, like unconsciousness for very long time, then and again it like this. But it's not like just fall down and get up in few seconds. And very importantly, focal deficit. After that injury, he realized that in his hand, movement is less, or there's some abnormal sensation in the hand. Okay, so that's one of the things. Okay. Or they start talking abnormal things actually. Or certain recent thing is gone. Retrograde amnesia. Start losing few things. So then you need a CT scan. Clear now, everyone? The indication of CT scan in heredity. And this is a very important topic. Even though it's emergency part, but I thought of introducing a little early. Yeah, irrelevant talk. Yes, well done. Okay. Good. Okay, done. Yeah, basic treatments are given according to the based on the chat scoring on the basis of the chat scoring. Rhinorrhea, falling the nose with the nose, maybe blood came up from the ear, blood came up. These are direct indications, right? Okay, like a something base of the skull injury, from the nose, from the ear, things came up. That's silent actually. Okay, so here's the thing. So antiplatelet based on the chats nowadays we give the treatment. And diagnosed by CT scan, nothing much here. DD, you can just check the DD, many things it can be. And must check the CT. This is ischemic strokes. Some complication. That's quite MBBS level thing. Like stroke patient can develop deep vein thrombosis, bed sore, infection, pneumonia. Anything can be possible. Even pulmonary embolism can be possible. Have a look. Last but not the least, management of stroke, ABC, mandatory. Then the supportive care and particular medication. If ischemic stroke, you can consider by discussing the doctor, like whether aspirin or clopid is important or not, or also heparin and that thing. If it's ischemic, you need a heparin and that. Also, all the things are like you see supportive care. Blood pressure high, you reduce the blood pressure. One quick question: if you see a stroke patient, is it ideal to drop down the blood pressure very fast. Say blood pressure is picked up to 180 by 150. So you want to give a very high dose to reduce it quickly? No, no, very slowly, very slowly. Okay, please keep that one in mind. I exactly forget that one. Per hour, was it like a 15 or 15% in 1 hour? No, I remember that. Please correct me if I'm wrong. I forgot that term actually. In 1 hour, 15%. Someone mentioned 25% in 2 hour, kind of like that. Yeah, 10 to 15, like that. I'm right, I think. Okay. So somewhere I read actually, because different guideline can be different actually. So somewhere I read in first hour actually, especially, should not be more than 15%. Later you can think about more. All right. And you might need catheterization, this, that as well. All right. So are you good with the stroke thing, guys? All good with the stroke? Understood the stroke a bit. We're not done yet. Stroke, we still to go subarachnoid hemorrhage, subdural hematoma, extradural hematoma. This particular thing are coming up now actually for you. Okay. But other than that, we just talked about the stroke in proper, and some of the neuroanatomy is this clear. After finishing the some of those hemorrhagic stroke coming up, we will get into the spinal cord related thing. Okay? Let's see what do we have here. Now if you open into the John Muttak, you see a very scattered something they have written. It may not cover the MC thing. So I mentioned as the SMA node, and also you check the extradural, subdural, and subarachnoid hemorrhages actually. So here's some facts given. They also mention about ordering the importance of CT scan and this, that. Okay. They also talked about the risk factor and some epidemiologies, some DD, I think. I'm just checking if anything we missed. And the management. So management, I think better you see from here is more recommended because it's John Muttak 8. So management, treatment, always check from the main one actually. Okay, so always exclude the head trauma. This is very, very important. Epidemiology, the typical epidemiology, like, is not in that way important. Okay, and unless if it is related to biostat question, then it's important. But typical, it's not much actually. So you can see TIA they mention. All of a sudden, just give it tick. You will understand when you see this. And here is the thing: carotid artery stenosis and vertebropapillar artery syndrome. This one, I think you have a look one time, but we do have a note in our note section is a carotid endarterectomy. From there, actually, most of the question that comes actually, rather than these two. But these two at least give it tick, so you at least see these two actually. Okay. We will be discussing the carotid endarterectomy very shortly. I'm just highlighting. Yeah, this is another. Amaurosis fugax. Is this kind of like also TIA? I mean, those of you who are familiar with this amaurosis fugax, it is one of our ophthalmology class topic. Very important. I will show you a fundoscopy as well. Is this somewhere related to transient ischemic attack? Suddenly, they have some symptom and they couldn't see properly. So transient loss of vision. It is nothing but a risk of a stroke. So suddenly they couldn't see and suddenly they start seeing. So that's a sign, amaurosis fugax. So give aspirin immediately. I highlighted this line. And in this case, this particular thing can happen because of the narrow carotid stenosis. So carotid endarterectomy might be required actually. There are some criteria for carotid endarterectomy which we will see later. Investigation mentioned again same thing, CT scan and carotid Doppler, cerebral angiography, this, that. Here is this one I want you to highlight, but even though we do have a note, guideline for carotid artery stenosis.
70 to 99%
70 to 99% intervention,
up to
up to
70%
70%
gray
gray
area,
area,
refer.
refer.
Less than
Less than
50
50
just
just
observe.
observe.
Okay, so above
Okay, so
70 or more than
above 70
70
or more than
intervention.
70 intervention.
That's one of the things.
That's one of the thing.
And here is a
And
chat
here is a
scoring thing is
chat
given.
scoring thing is
Indication
given.
of carotid
Indication of
tropular.
carotid tropular.
Last I think I
Mentioned
mentioned
most
most
of
of the
the
stroke
stroke
in
in
children
children
is
is
can
can
be
be
because
because
of
of
the
the
vasculitis.
vasculitis.
Alright, nothing much in
Alright,
this
nothing
chapter.
much in this
I think
chapter. I
note
think
will cover
note will cover
more than enough. I
more
think.
than
Right?
enough. I
What do you
think.
think?
Right? What do you think?
Yes.
Yes.
So you see,
So you
nothing much
see,
is here.
nothing much is here.
Unfortunately, nothing much is
Unfortunately,
here.
nothing much is
If
here.
you would have been
If you would
only
have
read
been
the John
only read
Montag,
the John
do you
Mottag,
really think
do you really think
it covers
it
the
covers
syllabus?
the
Actually,
syllabus?
technically not
Actually,
actually. So
technically
you have
not
to
actually. So you have to
make a combination
make
like
a combination like
pica, ica,
pica, ica,
then this
then
middle cerebral
this
artery,
middle
posterior
cerebral
cerebral
artery, posterior
artery.
cerebral
They
artery.
keep asking
They
question
keep
from these
asking question
areas.
from these areas.
Yeah, so very very
Yeah,
important.
so very very
So
important. So
try follow the
try follow
classes,
the
which
classes,
is number
which
one
is number
priority
one
for all
priority
of you.
for all of you.
Do you guys want a break
Do you
now?
guys want a
Because we
break now?
just finished a
Because we
big
just finished a big
stroke thing.
stroke thing. But
Even though
even though
I think
I think
we have the
we have
subdural
the
hematoma,
subdural hematoma,
epidural hematoma,
epidural
subarachnoides.
hematoma,
So two
subarachnoides. So
like
two
interesting
like
thing.
interesting thing.
Some of the interesting
Some
thing
of
are
the
coming up.
interesting thing are
So
coming up.
let's go for a
So
break
let's go
actually.
for a
Next
break
topic,
actually. Next
subdural
topic,
hematoma,
subdural hematoma,
epidural hematoma,
epidural hematoma,
subarachnoid hemorrhage.
subarachnoid
Easy
hemorrhage.
peasy topic.
Easy
We do
peasy
have
topic.
notes
We do have
in the
notes
notes section.
in
So
the notes
don't worry
section. So
actually.
don't worry actually.
So that's easy one.
So that's easy one.
I'll show you.
I'll show you.
The one slide would
The
be more
one
than
slide would
enough.
be more than enough.
The most
The
toughest
most
part in MC
toughest part
journey you
in
just
MC
go
journey you
going
just
through
go
actually.
going
I
through
try to make
actually.
it
I
little
try to make
interesting.
it a
So
little
this one I'll show you.
interesting. So
These
this one
the
I'll show you.
upcoming
These
ones
the
would be easy.
upcoming ones
Don't
would be
worry.
easy. Don't worry.
Alright. So let's take a
Alright.
break.
So
We'll
let's
come
take a
back after
break.
the
We'll
break
come back
and
after the
we'll
break
continue
and we'll
actually.
continue actually.
We'll come back. We'll
We'll come
discuss
back.
about
We'll
the
discuss about the
epidural hematoma
epidural
and the subdural
hematoma and the
hematoma.
subdural hematoma.
Nerve road is a part
Nerve
of
road
our
is a part of our
orthopedic, not here. Thank you.
orthopedic, not here. Thank you.
Yes, there is a
Yes,
hard.
there is a
Some
hard.
people don't
Some
have
people don't have
even basic,
even
so they
basic.
might be
So
in
they might be in
trouble, but you can
trouble,
cover
but
up
you can cover up
by
by
revise very quickly.
revise very quickly.
That's the thing. Yes,
That's
10
the
minute
thing.
break.
Yes, 10-minute
That's
break.
the thing. But
That's
you
the thing.
see,
But you see,
70% people understood
70%
as
people
this,
understood as
and
this.
there's 20 to 30
And there's
understood
20
because
to
they have
30
a
understood
very
because they
long
have a
gap.
very
They
long
forgot
gap.
about
They
what is
forgot
even
about what is
cerebral
even
cortex, this,
cerebral
that
cortex,
actually.
this, that actually.
Right. So you
Right.
can
So you can
discuss with your study
discuss
partner
with your
one
study
time, two
partner
time the
one
same
time, two times the
things.
same
It will
things.
come back to
It
you.
will come back to you.
Understand one thing. Everything
Understand
in
one
your
thing.
brain.
Everything in your brain.
Yeah, some concept
Yeah,
can be
some
new, like
concept
the
can be
artery
new, like the
related,
artery
this
related,
thing I mentioned.
this thing I
But
mentioned.
with
But
practice,
with
you can
practice,
always
you
do
can
it actually.
always do it actually.
But don't
But
give up.
don't give
Okay,
up.
if you give up,
Okay, if you give up,
then it's gone.
then it's gone.
Okay, so
Actually,
you can't give
okay,
up.
so you
Actually,
can't give
that's
up.
the main
Actually,
thing.
that's the main thing.
All right.
All right.
Yeah, we don't do
Yeah,
that, my
we
dear.
don't do that, my dear.
And in main class
And in
about
main class
recording,
about
never
recording,
mention anything.
never
It is
mention
spoil my
anything.
mood
It is spoil
actually.
my mood actually.
Be careful.
Be careful.
Last day,
Last day,
I put someone
I
in the
put someone in
waiting
the
zone
waiting zone
because I was asking
because I was
too many
asking
things
too
about
many things
recording,
about
recording, spoil the mood
recording.
all the time
Spoil
in
the
the
mood all
class.
the time in the class.
For
For
individual
individual
thing,
thing,
I've
I've
been
been
running
running
for
for
9 years.
9 years.
So
So
for
for
individual
individual
something,
something,
I'm
I'm
not
not
going
gonna
to change
change
things. You
things.
need to
Something.
understand.
So you need to
We
understand.
design
We
in best
design
possible
in
way.
best possible way.
Okay.
Okay.
Individualized persons
Individualized
demand this,
persons
that, but
demand this, that, but
we are experts
we
here
are
actually,
experts here
especially
actually,
in terms
especially
of the teaching
in terms of
things,
the
how
teaching
it's
things,
going in your
how it's
brain,
going in your brain,
how I'm getting the
how I'm
feedback,
getting the
all
feedback,
this thing. I
all this
have
thing. I
researched
have
many on
researched
students,
many
at
on
least 10,
students, at least
15,000
10,
I've taught
15,000 I've taught.
MBBS, dental,
MBBS,
post
dental,
graduation,
post graduation,
online. Okay.
online.
Anyways,
Okay.
let's go
Anyways,
and
let's
let's
go
stay
and let's
focused.
stay focused.
Always same system. We
Always
will
same
understand
system.
this
We
thing.
will
Yes.
understand
Let's
this
go
thing.
for a
Yes.
10
Let's
minute
go for
break.
a 10-minute break. Okay, everyone. Sorry about a little bit.
Ready,
Yes.
guys?
Ready, guys?
Okay.
Okay.
Let's focus on this
Let's
one.
focus on
We
this
also
one.
do have
We
note.
also do have note. Okay.
Let's also
We do have a note in our note section.
So you can also check it
So you
from
can
our
also check it from
notes as
our
well.
notes
Okay.
as well.
So
Okay. So
we have come across
we
the
have come
stroke
across
related
the
thing.
stroke related thing.
Stroke
I mean,
in
mainly
proper.
stroke in
We are
proper.
still going through
We
the
are still
stroke,
going through the
especially at
stroke,
the end of the
especially at
stroke,
the end of the stroke,
some of
especially
the hemorrhagic
some of the
strokes are coming
hemorrhagic
up now.
strokes are
They're like,
coming up now. They're like,
epidural hematoma,
epidural
subdural
hematoma,
hematoma,
subdural
and
hematoma,
following the
and following
subarachnoid
the
hemorrhage actually.
subarachnoid hemorrhage actually.
Okay. Now,
Okay. Now let's
focus
come and focus
um, into this CT
into
scan
this
first
CT
actually.
scan
Okay,
first
because
actually. Okay,
this
because
particular
this
question
particular question
often comes with a
often
CT scan.
comes with a CT scan.
Okay.
Okay, this
Question
particular
often
question
comes with CT
often
scan.
comes with CT scan.
No.
No,
Left hand
the
side.
left hand side.
If this type of thing
If
is
this
given
type of thing
after a
is
motor
given after a
vehicle
motor
accident,
vehicle accident,
if this type of
if this
scenario
type of
is given,
scenario is given,
the left hand side.
the left hand side.
Okay. So in that
Okay,
case,
so in
what
that
do you
case,
think?
what do you think?
What can be your
What can be
diagnosis?
your diagnosis?
This one,
This one,
it's a shape.
it's a shape.
It's called
It's called
biconvex.
biconvex,
Biconvex.
biconvex.
This
So
extradural
this
hematoma.
extradural hematoma.
Let me as a short
Let me
thing
as a
here.
short
Actually,
thing here. Actually, I
do remember
do
long
remember
back story.
long back story.
Of course,
Of
I
course,
grown up in the
I
local
grown up
city,
in the
not
local
in
city, not
capital
in
Dhaka.
capital
So
Dhaka.
people
So
used to ride
people
bike a
used
lot.
to ride bike a
I
lot.
do have
I do have
restriction that
restriction that
by my father that
by
you
my
can't
father that you can't
ride bikes.
ride bikes actually.
Anyways,
Anyways, and also, I mean,
I was not allowed
I
to
was not allowed
even
to
go with the friends
even
with the
go
bike,
with the
but
friends
whatever
with the
it is.
bike, but
So
whatever it is. So
bikes was very
bikes
popular
was very
locally.
popular
Many of
locally.
our friends do
Many of
have
our
bike.
friends do have bike.
Now, thing
Now,
is,
thing is,
one day I got a
one day I
call
got a
because
call because
previous
previous
days
days
it
it
was
was
not
not
mobile
mobile
like
like
TNT
TNT
phone,
phone, and
and so
so
we
we
got
got
a
a
phone
phone that
some of our friend
some
is
of
in
our
a
friend
uh,
uh,
is in a
is in a
bike accident.
bike accident.
Okay.
Okay,
So in a bike
so in
accident,
a bike accident,
they are
and
taking them to
they are
the
taking them to the
medical college hospital.
medical college hospital.
Now, if it
Now,
because
if it because
we went there
we
and there
went
were
there and there were
like a
like a
two friends,
two friends,
and thing
and
happened.
thing
Three friends.
happened.
Sorry, there
Three
were
friends,
three
sorry,
friends
there were
because
three friends
the
because
three people
the three
often
people
get in the bike
often
and
get
there's
in the
more
bike and
chances
there's
of.
more chances of.
So three people.
So three people.
So
So
thing happened that
thing happened that
the person who was
the
riding
person who
and the
was
middle
riding and
person
the
they
middle
were more
person, they
injured
were
actually.
more injured actually.
Okay, so it was kind of
Okay,
like
so it
that.
was kind of like that.
So one of
So
them and
one
even
of them
taken
and
to the
even taken to the
theater actually
theater actually
because of the injuries
because
and
of the
this that.
injuries and this that.
The one who
The
was fine
one who
and
was fine and
scratch
little
and
scratch and
bruises.
bruises.
Um,
Um,
he was. I mean, we went
I
and
mean, we went and
we met
we
him
met him
in the emergency.
in the
Because
emergency,
little dressing and
because
this
little
that were
dressing and
done.
this that were
He was
done.
talking with
He
us
was
actually.
talking with us actually.
So you're concerned about the
So
other
you're concerned
friend.
about the
Like
other
suddenly you
friend.
heard
Like
that
suddenly
something
you heard that
happened with that
something
friend,
happened with that friend,
and after that,
and
he
after
just
that,
collapsed.
he just
And later,
collapsed. And later,
because that
because
particular time
that particular
ICU and
time
this that thing
ICU and
was
this
not
that thing
that
was not
popularized that
that popularized that
very quickly you can
very
rush
quickly you
to
can
an ICU
rush to an
always.
ICU always.
So we keep knocking the
So we keep
doctors. This
knocking
that
the
we heard
doctors.
that
This is we heard that already
surgeon took him
one
to the
surgeon took him to the
surgery, and another was
surgery, and
called who was
another was
coming.
called who was coming.
So later thing
So
happened, he
later
died.
thing happened, he died.
Okay, so
Okay,
it's
so
very clearly
it's very
visible,
clearly
and
visible,
we
and
clearly
we
remember
clearly remember
the person who
the
was
person
in
who
that
was
accident
in
was
that
talking to
accident was
us
talking to
and
us
died
and
afterwards
died
actually.
afterwards actually.
Okay, so this
Okay, so this
phase is called
phase
a
is
lucid
called a
interval. Have
lucid
you heard about
interval.
that?
Have
So
you
if
heard
it is
about that?
called
So if it is called
short lucid
short
interval,
lucid
it was
interval,
short,
it
like
was short,
for a
like a
1 2
for
hour,
a one
he
two
was
hour,
fine,
it was fine,
and after that,
and after
bang,
that,
everything
bang,
deteriorates.
everything
So
deteriorates.
talk and die
So talk
syndrome.
and die syndrome.
This is applicable
This is
for
applicable
this
for
particular
this
condition
particular
actually.
condition
That
actually.
is what?
That is
That
what
is
epidural hematoma. This particular condition is called epidural hematoma. This is the particular layer that is affected, and middle meningeal artery is affected. So arterial layer is more affected, whereas in subdural hematoma, vein is more affected actually. So you can see the difference because it's artery affected, it's written in red. It is the vein affected is written in blue actually. Okay. Now, how subdural hematoma question does come is another one. Is a motor vehicle accident. Helmet is broken into two pieces. Motor vehicle accident. Helmet is broken into two particular pieces. Okay. So, in that case, what to do? Okay. So, in that case, what to do? All right. So if helmet is broken into two pieces, in that case, what you can do is and the patient, sorry about that, and sorry, and the patient was fine in the hospital. He was brought because of injury. He was observed for 24 hours, and after 2 weeks, again he was brought. His condition deteriorating. So this is what? This is the classic lucid interval and a long lucid interval, and the diagnosis is a subdural hematoma. And diagnosis is a subdural hematoma, a long lucid interval. Motor vehicle accident, helmet broken into two pieces. Still the patient was fine, but later it happened. Another similar example with the subdural hematoma I found, there was a history of injury while getting up from a bathtub. Bathtub. I mean, lot of. I don't see any that much function of bathtub. I mean, in our country, a lot of toilet they made bathtub, but it's like always we don't take the bath. I mean, with the bath bomb and this that, right? That is very tiny, to be honest, actually. Yeah. So especially many people get up into the bathtub, and still that's the shower. Actually, I don't find any point actually. So often they slip into the bathtub actually. Okay, so initially they thought it's minor, they don't tell anyone, and later many it came up like that. So when you take history properly, there's a bathtub related injury is often common actually. So if there is any elderly people at your home, your parents, grandparents, whoever is old, and using the shower in the bathtub, ask them to avoid that one. One day, 2 day, 3rd day, any day they can fall down. It's never a good choice. Having that shower in a bathtub actually. Still you are taking the shower standing in a, not a good idea, and it's very slippery. Okay, so be careful with that particular thing. Okay, clear about that? Clear about this epidural hematoma and subdural hematoma? Let's come and see something about this. Let's see a question. Okay, let me show you guys a question for as a final finishing. So here is that question. 88-year woman found wandering aimlessly. This particular word they will use a lot in MC. Wandering into the street, wandering this, that. So 88-year woman is found wandering aimlessly by the police. He brought to the ED means emergency room, where a nurse recognizes patient as someone who was admitted 4 weeks ago after sleeping in her bathtub. Okay, I was talking about it. Hitting her head. The patient is confused and only knows her name. Okay. But she does not know other information. Pain localized in her head. She opens her eye in response to painful stimuli. Pupils are unequal. This is the red flag. Even in a head injury case, even if there is pupils are unequal and fixed, it's another indication of head injury, by the way. Now, what is your diagnosis? Actually, so here's some diagnosis been asked. What is your diagnosis? It's a subdural hematoma. It is a subdural hematoma. What is the most common vessel affected? Another thing. What is the most common vessel affected? Is it the vein? Is the artery? Answer: vein affected. Next, what is the next best step? In this case, what you want to do next? Of course, you like to do a CT scan.
What is the most
What
appropriate
is the most
therapy?
appropriate therapy?
I hope you must be
I
knowing.
hope you must be knowing.
In these
I mean,
cases,
in
after
these
CT, what
cases,
we
after
do, if
CT,
it
what we do,
diagnosed as
if
a
it diagnosed as a
subdural, so in that case,
subdural,
what you
so in
do,
that case, what
so
you do? So
we like to go
we like to go immediate surgical evaluation, surgical evaluation, bar hole or craniotomy, ruling out this actually.
Clear everyone?
Clear
So
everyone?
subdural
So
cases, you will
subdural
find a
cases, you will
crescent
find a
shape,
crescent shape,
whereas in
whereas
epidural you will
in
find
epidural you will
convex
find
shape.
convex shape. So convex
crescent.
and
So this
crescent.
bit
So this bit
longer crescent
longer
shape.
crescent
Clear
shape.
everyone?
Clear
Is
everyone?
this clear?
Is this
Subdural
clear?
hematoma,
Subdural hematoma,
these
epidural
things.
hematoma, these
I
things.
hope you can
I hope you can
make the right thing
make
now
the right thing
for
now
the
for
epidural
the
hematoma
epidural
and
hematoma
the subdural
and the
hematoma.
subdural hematoma.
About the subarachnoid
About the
hemorrhage, we
subarachnoid
also
hemorrhage,
do
we
have
also do
note in
have
our note
note
section,
in our
but
note
I will just
section, but
open
I will just open one
particular
particular
slide.
slide.
Okay.
Okay.
Just try to show you
Just try to show you
a particular
a
CT
particular
scan.
CT scan.
This is normal.
This is normal.
This
This
is
is how
how
a
a normal
normal
CT
CT
scan
scan looks like.
looks like. You can see the
You can see the
sulcus,
sulcus, gyrus,
bones.
bones.
Now,
Now,
different people want to
different
define
people want to
subarachnoid
define
hemorrhage in a
subarachnoid
different way.
hemorrhage in a different way.
How does it look
How
like?
does it look like?
Is it a frog?
Is it a frog? Is it a spider?
That's your opinion.
That's your opinion.
So it will be
So
given like
it will
that. A
be given like that.
40-year
A
person,
40-year person,
you know,
you know,
who recently
who
had
recently had deteriorating level of consciousness.
on examination, you
On
find
examination, you
neck
find
rigidity.
neck rigidity.
He has a history
He has a
of
history of
some kidney issues
some
in
kidney
past.
issues in past.
Okay.
Okay.
He has a history of
He has a
some
history of
kidney issues
some
in
kidney
past.
issues in past
To be
actually.
honest,
To be honest,
subarachnoid
subarachnoid hemorrhage has
close
close
association
association
with
with
adult
adult
polycystic
polycystic
kidney
kidney
disease.
disease. Did you know this information? Subarachnoid hemorrhage has association with adult polycystic kidney disease. This is a very key thing.
Okay.
Okay.
They have association
They
with
have
more
association
other
with more
conditions
other
too.
conditions too, like yeah.
But
But
main reason of
main reason of
having subarachnoid
having
hemorrhage is
subarachnoid hemorrhage
a
is a
rupture
rupture
of
of the
the
Berry's
Berry's
aneurysm.
aneurysm.
Rupture
Rupture
aneurysm. Rupture Berry's aneurysm actually.
So
So
the same question.
the
What
same
you
question,
like to
what
do
you
next?
like to do next?
Okay, if you
Okay,
suspect,
if you suspect,
what you like to do next?
what
So
you like to
next
do
is a
next? So
CT
next
scan.
is a
You do
CT
a CT
scan. You do
scan
a
and
CT
you find
scan
out this.
and you
So this is
find
how
out
question
this.
will
So
be
this is
given.
how
They'll give
question
you
will be given.
scenario
They'll give you scenario
and
and
yeah.
yeah.
A quick question.
A quick question.
Are you expecting
Are you
focal
expecting
neurological
focal
deficit?
neurological deficit?
Are you expecting?
Are you expecting?
Already mentioned.
Already mentioned, which
Rupture
I
Berry's
mean, rupture Berry's
So
aneurysm
those
actually. So
anterior
those anterior
cerebral artery,
the communicating arteries, those become affected often actually. But it can be because of the posterior communicating too. Okay, clear? Anterior communicating, some cases posterior communicating.
Okay, so here is
Okay,
the thing.
so here is the thing:
Subarachnoid
subarachnoid hemorrhage. That's the thing.
And a special
And a special feature is the association with the adult polycystic kidney disease.
important. So
It's very important. So this more looks to me like a
some say
frog,
chicken,
some say chicken, some say whatever.
Yeah.
Yeah.
I like
personally this one. This is not a real city, but I'll try to make a real one. With the real one, this is just they're just trying to show the shape.
So it is like
So it is like a convex shape,
epidural
epidural hematoma,
crescent
crescent shape, or more sharp subdural hematoma.
This is typical
This is typical hematoma,
or typical
or
stroke.
typical stroke.
Okay.
Okay.
And
And
like spider
like spider in the middle,
subarachnoid
subarachnoid hemorrhage.
And last but not the
And
least,
last but not the least, diffuse axonal injury, DAI.
It's another
It's another
this,
version of this, but that never
been
tested actually.
Okay.
Okay.
It's a little
It's a little
thing.
drawing thing.
Things should be clear.
Things should be clear now.
We do
We do already have a note in the note section, so do not worry. All this information you will find.
No.
No.
As you can see
here, like a subarachnoid hemorrhage is nothing but a stroke.
There will be weakness.
There will be weakness in the,
you know,
you know,
weakness,
weakness, particularly in the
anterior cerebral
anterior
artery
cerebral
areas.
artery areas.
Basically, there is a aneurysm
Because
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 aneurysm rupture
aneurysm
actually.
rupture
Okay,
actually.
because there
Okay,
is a
because
aneurysm
there
rupture.
is a
My dear, I
aneurysm
mean, if
rupture.
you
My
have a
dear, I mean, if you have
separate
a
question other
separate
than
question other than
subarachnoid
the
hemorrhage,
subarachnoid hemorrhage,
we do have a
we do
inquiry
have
zone.
an
You can also
inquiry zone.
drop
You
your
can
question
also
there
drop your
actually.
question there actually.
All
Okay,
right.
all right.
Right. Coming
Right.
to that one,
Coming to
main
that one,
cause.
main cause.
Focusing on main cause.
Focusing on
Guys,
main
remain
cause.
stay
Guys,
focused.
remain
Don't
stay focused.
push your
Don't
mind here and
push your
there.
mind
Too
here
much
and there. Too much
curiosity is not good
curiosity is
sometimes.
not good sometimes actually.
So
So
far,
so
so
far,
many people have
so
been
many people
studying.
have been
So
studying. So
already should be curious
already
on
should
your
be
own
curious
studies
on your own
actually.
studies
During class,
actually.
don't get
During
too much
class, don't get
curious
too
on
much curious
side
on
things
side
actually.
things
Okay,
actually.
so
Okay,
that you don't
so,
get
so that you
distracted
don't
and
get
others don't get
distracted and others
distracted.
don't get distracted.
Okay.
Okay.
Now here we go.
Now here we go.
Is a
Is a
rupture belly
rupture
aneurysm is the
belly
main thing.
aneurysm is
So
the
it can
main
be
thing.
either
So
by
it
a
can be either by
weakness,
a weakness,
congenital,
congenital,
family, traumatic.
family,
Okay,
traumatic.
rupture
Okay,
belly
rupture
aneurysm. Now
belly
how it
aneurysm. Now
presented, they
how it
will mentioning
presented, they
about
will mentioning
Or's
about
headache effort. That's
Or's
like in
headache
gout.
effort. That's like in gout.
Or's pain ever, Or's
Or's
headache
pain
ever,
ever, Or's headache
photophobia,
ever.
conscious
Photophobia,
neck
consciousness,
stiffness,
neck stiffness,
focal neurological
focal
deficit.
neurological
So I
deficit.
mentioned that one.
So I
Focal
mentioned that
neurological
one. Focal
deficit can be
neurological
also
deficit
common,
can be also
especially
common,
cranial nerve
especially cranial nerve
3 and 6 can
3
be
and 6
affected
can
in
be affected in
subarachnoid hemorrhage.
subarachnoid
Additionally,
hemorrhage.
we have seen some
Additionally,
clue.
we have seen some clue.
And deteriorating level
And
of
deteriorating
consciousness
level
and
of
headache, these are
consciousness and
become a
headache, these
major
are
thing.
become major
Neck
thing.
stiffness is
Neck
always not
stiffness is
present,
always
but if
not
it is
present, but
present,
if it is
it's
present,
always quite
it's
a sure
always
thing.
quite a sure
So
thing.
what you do first
So
line
what you
already
do first
mentioned
line
CT
already
scan.
mentioned CT scan.
Now another
Now
thing,
another
when
thing,
is
when is
lumbar puncture? Like
lumbar
sometimes
puncture.
they will
Like
offer you
sometimes they
lumbar
will
puncture
offer you
if
lumbar puncture.
CT
If
finding is
CT finding is
inconclusive.
inconclusive,
If CT
if
finding is
CT
inconclusive, like
finding
you
is
did CT
inconclusive, like you
still you
did
are
CT, still
confused,
you are confused,
in that case you
in
will
that
do
case, you will do
the lumbar puncture.
the lumbar puncture.
Okay.
Okay.
In that case, what you
In
will
that
do
case,
is
what you
a
will do is
lumbar
a
puncture.
lumbar puncture.
Okay.
Okay.
Now, coming to the
Now,
subarachnoid
coming to the
hemorrhage, I'm sure
subarachnoid
many
hemorrhage,
of
I'm sure
you
many
have
of
treated
you have
subarachnoid
treated
hemorrhage or
subarachnoid
has
hemorrhage
written
or
at least
has
a
written at
fresh
least a
order
fresh
for
order
subarachnoid
for
hemorrhage for your
subarachnoid
professor.
hemorrhage for your professor, right?
So, other than many
So,
things,
other than many
ABC,
things,
catheter
ABC,
supports,
catheter
and this, that,
supports, and this,
what is the
that,
particular
what is the
drug
particular
you
drug
mention
you
in the
mentioned
chart?
in the chart?
So, that is the
So, that
pneumocol
is
or
the pneumocol or
nimodipine. So,
nimodipine.
2 plus 2
The
plus 2
2
plus
plus 2
2,
plus 2 plus
remember?
2, remember?
Yes. So,
Yes.
this is like a
So, this is
important.
like a important.
Yes. Okay, so
Yes.
this is important.
Okay,
This
so
is
this is important.
basically
This is
does what?
basically does what?
It prevents
It prevents
vasospasm. How it
vasospasm.
works?
How it
The
works,
nimodipine
the
is prevent
nimodipine,
the
is
spasm. When
prevent the
spasm is
spasm. When
prevented, it
spasm
would
is
be less
prevented, it
bleed.
would be less bleed.
That's the mechanism.
That's the mechanism.
Okay. So after
Okay.
medical
So after
management,
medical management, is
the
medical management
mainstay.
is the mainstay.
What do you think?
What do you think?
Is medical
Is
management
medical
is the
management
mainstay?
is the mainstay?
Answer is a no.
Answer is a no.
Main management is the
Main management
surgical.
is the
Surgical
surgical.
management would be
Surgical management would be
coiling and the
coiling
clipping.
and the clipping.
Now,
Okay.
there's another
Now,
question.
there's another
Long back it
question.
was
Long
tested,
back
but
it was
it can be
tested, but
tested
it
again.
can be tested again.
They asked, given
They
the
asked,
scenario of
giving the
subarachnoid
scenario of
hemorrhage,
subarachnoid hemorrhage,
and they were
and
asking
they were asking
which one is more
which one is more
preferred.
preferred,
Which one was more
which one
preferred
was more
treatment?
preferred treatment.
Okay, medically,
And
things are
medically,
done,
things are
and they were
done,
looking for
and
a
we're looking
surgical
for a
treatment, and their
surgical treatment,
preferred
and
one.
their preferred one.
Answer is a
Answer is a
coiling. Coiling another
coiling.
name is
Coiling, another name is
embolization. Okay,
embolization
so
actually.
be
Okay,
careful
so
that
be
they might
careful
also
that
give
they
you
might also give you
another. So this is
another. So
superior.
this is superior.
But what is done
But what is
mostly?
done mostly?
Okay, but which
Okay,
thing
but
is
which
done
thing
mostly?
is done
Mostly
mostly?
done is a
Mostly done is a
clipping. Is coiling is
clipping. Is
expensive.
coiling is
Coiling is not
expensive.
available
Coiling
in
is
all
not available
centers
in all
actually. So
centers actually.
most
So
cases they
most
just try
cases
to
they just try
clip
to
actually.
clip
That
actually.
particular area has
That
issue.
particular area has issue.
They have done CT.
They have
They have
done
done
CT.
cerebral
They have done
angiography.
cerebral
They
angiography. They
locate the site of the
locate the
lesion
site
and they
of the
just go
lesion
and
and they just go and
neurosurgeon
neurosurgeon
clip that particular
clip
area.
that
Of course,
particular
they
area. Of
gone through
course,
by
they gone through
bar
by
hole and this
bar
that.
hole and this that.
Okay. So this
Okay.
is important.
So this is
The
important.
biggest risk
The
about
biggest risk
subarachnoid
about
hemorrhage, this is
subarachnoid
another
hemorrhage, this is
earthquake.
another earthquake.
Okay, so once
Okay,
there is a
so
chance
once
of
there is a chance of
this is stroke, there's
this is
another
stroke,
huge
there's
chance,
another
especially
huge chance.
subarachnoid
Especially
hemorrhage,
subarachnoid
recurrence rate
hemorrhage,
is very,
recurrence
very
rate
high.
is very, very
Clear
high.
guys?
Clear,
In
guys?
subarachnoid
In
hemorrhage
subarachnoid
cases, the
hemorrhage
recurrence
cases,
rate
the
is
recurrent rate
very,
is
very high.
very, very high.
Alright? So
All
these
right.
are some of the
So these are some of the information related to your subarachnoid hemorrhage. Here is a small chart. This is already given in the notes, so you don't have to go through it. So in this sub emergency CT is done. If it is negative, later you can do CSF. So there was another question I found in MC, that CT is done, but still
inconclusive.
inconclusive.
So what you need to
So
do
what
is
you
a
need to do is a
lumbar puncture.
lumbar
Now
puncture.
clear everyone?
Now clear
In the
everyone?
investigation
In the
wise,
investigation wise, you
you
have to remember the
In
city.
investigation,
In investigation, you have to remember the
lumbar puncture. as well.
lumbar puncture
Lumbar
as well.
puncture,
Up
they
to
have
lumbar
tested.
puncture, they have tested already.
Okay.
Okay.
Okay, let's practice
Okay,
one
let's
more.
practice one
54
more.
year
54 year
by
hits a tree by skiing, lose consciousness, awakening in ambulance, again lose consciousness in emergency department. Now this is a red flag. Again lose consciousness. Physical ignition reveals unequal people, so unequal people is not a good sign. Patient only opens eye in painful stimuli means DCS is very much down. In campus or ward, this is down. Withdraw from painful stimuli. Now, what is the most likely diagnosis? What do you think, guys?
So head injury.
So head injury
Without having CT scan,
without having CT scan is difficult to tell, but
what do you think?
what do you think?
So this one is a
epidural hematoma. So because we just finished the subarachnoid hemorrhage, I'm very glad that you guys didn't put your feet into that. Okay, so I'll strike to add a bamboo here actually.
So this one is a
epidural hematoma actually. Most commonly affected vessel is the artery. You need CT. Next is a evacuation and this that surgical evacuation. Bar hole and craniotomy will be important. But the rest is same as the subdural hematoma. Clear everyone?
Clear this one.
Clear this one? All
Well
good.
done, guys.
Well done, guys.
So
So we just now finished few things about. Here we go. Neurotomy, upper motor, lower motor. Last day we did. I hope so you remember that. And stroke, TIA, epidural, subdural hematoma. This that. Then our long-awaited Bell's palsy. Okay, can you go with the Bell's palsy now? Class 8 came, but I mentioned that we can reduce the pressure a little bit and we can go with a very, very important one, that is the Bell's palsy. And fifth cranial nerve related, another very, very important trigeminal neuralgia, which we also did today, right? Another cranial nerve related trigeminal neuralgia related issue that we did today. We do have a note. And before going to the Bells, one more thing.
This one is a popular.
This one is a popular in the exam.
What is it?
What is it?
This
Big particular picture.
Your
Your
if
you see the position of the eye down and out.
If
Position of the eye is a down and out, what does it mean? It means oculomotor nerve. This has been tested in your exam in past. Oculomotor nerve, eye position down and out because of the pull by the other nerves actually. Pull by the other muscles actually, which is working. So eye position down and out.
So in
oculomotor nerve palsy, eye position down and out. These are some of the muscles of the eye. This will come again in our ophthalmology. It's part of the ophthalmology as well. So drooping of the eyelid, mydriasis, and down and lateral gaze. So eye position down and out. Clear everyone about the oculomotor nerve? So very, very important. Oculomotor nerve, cranial nerve 3, cranial nerve 5 related one condition, that is the trigeminal neuralgia, very, very popular in the exam. And now we are getting into the Bell's palsy. Are you guys ready with the Bell's palsy?
Yes.
So here we go with the bells.
Okay.
Before getting into the Bell's palsy, are you guys already familiar with the upper motor and lower motor neuron? Last day I mentioned about the upper motor and lower motor. Upper motor neuron, cerebral cortex up to anterior horn cell of the spinal cord. That means anterior horn cell of the spinal cord is a part of the lower motor neuron. Clear? Anterior horn cell of the spinal cord is a part of the lower motor neuron. We already mentioned that one. Great. Okay. Coming to the Bell's palsy. Originally, Bell's palsy, what do you think? Is it a always upper motor neuron, always a lower motor neuron, or it can be anything? Okay, like it can be first of all anything upper motor or lower motor. Then if we count which one is more common, like typical Bell's palsy, you see someone's face is moved, both one side is affected. There's a popular line, affected side is motionless. Affected side is motionless. So Bell's palsy usually we mean by the lower motor neuron one. Okay, Bell's palsy usually we mean by the lower motor neuron one actually. Bell's palsy. Let me see again. Okay. So the typical one we mean by lower motor neuron. Now, how we can differentiate? If this is the face, this is the eye. Yes. So if this particular side is affected, let's say take a different color. Now, if this is the lesion, what do you think? What happened here actually? Now what do you think? What happened here? Is it upper motor, lower motor, or what do you think? This is upper motor neuron type of Bell's palsy. The question is coming, why? It is because forehead spared. Spared means not involved. So you can see here, this particular part is not affected. That means the eye is not affected. You all must be remembering about the Bell's palsy examination, close the eye against the rest and you ask them to, yeah. So that particular movement is not affected. So forehead is spared. Now if I fulfill all of them, in case if I fulfill all, now what it is? Now it is a lower motor type of Bell's palsy. In lower motor type of Bell's palsy, full side is affected. Upper motor type of Bell's palsy, forehead. Okay, forehead, that particular is affected. Like especially the forehead is affected. Especially the wrinkling. Sorry, I mentioned wrong. The wrinkle part is affected. Indeed. The wrinkle part. Okay, so forehead spared. That's the main thing. Clear everyone? Upper motor and lower motor type of Bell's palsy. Now, if I come to the main one, lower motor type of Bell's palsy, what are the main causes of lower motor type of Bell's palsy? Okay, idiopathic, herpes, salivary, herpes, salivary, trauma, diabetes, sarcoidosis, stone. But out of all of them, you have to remember viral cause. We always suspect there can be underlying virus. Now quickly tell me the management of the Bell's palsy. Of course we give the rest, eye drop, closing of the eye. We also give the steroid. Of course we do give steroid actually. Number one. Very important is steroid as soon as possible, and it becomes fine with some physiotherapy of the face. With some physiotherapy of the face becomes fine, right? Okay. If we suspect the antiviral, we can also give the acyclovir. Now this acyclovir you have to give within 72 hours. Acyclovir you have to give within 72 hours. Clear? Not good. Next coming about the Bell's palsy with some additional scenario. This will be helpful for solving lot of recalls. Okay, what is that? This one. Sorry about that. Here we go. Number one. Bell's palsy. Now you see jaundice. Why? Liver is affected.
Now this can be because of the virus.
It's a tricky one.
It's a tricky
But
one,
this can be because of
but this
virus.
can be because
If
of
you
virus.
remember,
If
the
you
cause
remember,
of
the cause of
hepatitis is.
hepatitis is,
Okay,
if you
just Google it,
just
or if you
Google it,
remember the
or if
David
you
syndrome,
remember
is
the David syndrome, is
hepatitis A to E are
hepatitis
the
A
only
to E are the
viruses,
only
or there were
viruses, or
named
there
like
were named like
Epstein-Barr virus,
Epstein-Barr
herpes
virus,
virus, were
were
there
there in the list
in the
in the
hepatitis,
hepatitis,
in the viral
in the
hepatitis.
viral
They were
hepatitis.
also there
They
if
were
you
also
just
there if you
put a little
just
pressure on
put a little pressure on your
on
brain,
your head
on your
actually.
head
So
actually.
herpes name
So
was
herpes
also
name
there
was
actually.
also there actually.
Okay, so
Okay, so herpes can also cause jaundice in that way by affecting liver and the bowels together. Because if it is a hepatitis, you are not supposed to have Bell's palsy. But jaundice plus Bell's palsy, when it's a combination, diagnosis is herpes. Clear now? Normally, typical jaundice hepatitis does not associate with Bell's palsy, but jaundice associated with Bell's herpes, definitely. Okay, now Bell's palsy is one of the cause can be parotid enlargement, parotid. Now, what do you think what has happened here? The tumor is actually compressing the facial nerve. Tumor is actually compressing the facial nerve. Okay, so that can be the thing actually. So Bell's with parotid enlargement, it is high possibility a parotid tumor. Most popular is they will ask you what to do next. Are you going to do an ultrasound? Are you going to do a CT scan? Are you going to do a biopsy? The commonly wrong answer is a biopsy. We know it's a tumor and you are going to do a biopsy or FNSC, but we like to do a CT scan first here. Why? To rule out how far the tumor has extended. It is very important to know. Otherwise, if you do the FNSC, what will happen? You might help in seeding. Tumor is spreading in that case. So CT first, then you go for the FNSC biopsy. Clear now? Okay, this is the thing. So painless cases, we start with the CT scan. If it is a painful case, painless and painful parotid, that can be sialadenitis, painful parotid, sialadenitis, then ultrasound. So painful cases, ultrasound, painless cases, CT scan or FNSC. So CT scan first and then FNSC. Clear everyone? So salivary gland swelling, that is how to deal with the investigation. Again, I'm repeating, painful cases ultrasound, painless cases CT scan. Okay. Next, Bell's palsy, and you find it's painful and vesicular eruption in the ER area, this area. What does it mean? It means, in that case, Ramsay-Hunt syndrome. Ramsay Hunt syndrome. Bells with vesicular eruption in the ear. Ramsay Hunt. Okay. Interesting question. Normally, the Bell's palsy you're talking about, it is a unilateral Bell's palsy, right? If you find bilateral Bell's palsy, okay, what can be the cause? In case of bilateral Bell's palsy, there can be like two, three causes like that, but for AMC, we'll remember the Lyme disease. LYME, not LIME. Lyme disease. Yeah. Is it LYME or LIME? Okay. Anyways, we'll check it. So it's a Lyme disease actually. So Lyme disease can lead to, yeah, I think Lyme disease can lead to, bilateral, Bell's palsy. All right. If you suspect viral, you always go with the acyclovir. Okay, understand the formula. If you ever suspect viral, you always go with the acyclovir. Next in the recall class, we'll see when acyclovir, when steroid, there will be some questions regarding that. But summary is acyclovir within 72 hours. Acyclovir within 72 hours. The basic treatment of Bell's palsy still remains the same. Even if you give acyclovir, a quick question. Even if you give acyclovir, are you going to still give steroid? Answer is a yes. All the remaining managements are same. Someone asked a question. Bell's palsy parotid enlargement is a very simple parotid gland tumor. Okay.
Great.
Alright,
So that's the clearance in the
So
Bell's palsy. So this particular side is done.
How do you feel
How
like
do you
actually?
feel like actually?
This particular
This
whole
particular
side is done.
whole side is done.
Yes. Ramsey
Yes.
Hunt.
Ramsey Hunt,
Bell's palsy.
Bell's palsy,
And
and you know
eruption in the air.
eruption in the air,
Vesicular eruption.
vesicular eruption, painful vesicular eruption in the air.
So
So that's the
Ramsey Hunt syndrome.
Ramsey Hunt syndrome. So you give analgesic for pain, you give acyclovir for that viruses. Clear now? Last year we also discussed this particular part. Stroke in a children. Stroke in a children actually.
Stroke in a children.
Stroke in a children is a vascular. Guys, those people couldn't get it. Please help them. Listening power is not same for all. Alright.
So let's take a minute.
Those people are inquiring. Try help each other actually. Some of you are very fast. I know. Yes. Okay.
Sistering in
Chile with the vasculitis, the Kawasaki, and many other conditions connected to vasculitis. Already we have discussed. We have done this cranial nerve 3, 5, 7, and Bell's palsy important. This is also done. Alright.
Let's check
the
carotid
endarterectomy, then get into spinal cord. What do you think, guys? Okay.
Let's check
the carotid endarterectomy, done with it, and let's just end finishing with the spinal cord diseases. Okay. We do have a nice note on carotid endarterectomy. I'm just taking off my screen
just to bring the notes. It's taking a second.
Don't get confused.
In next
5 seconds, there will be screen opening up.
Okay, I'm holding here
in a second. This section already we do have a note.
This is a good
note. I think I would say, like,
put lot of
effort on that one.
Okay,
let's come and see a case. A 59 of elderly patients with a visual disturbance that occurred one day ago, just one day, and elderly. He reports he experienced a curtain coming down.
You understand
curtain coming down? Like, we all have curtain
in our windows.
Some cartoons, I mean,
are like a
if you see some play,
I'm not sure.
I'm not sure. Have you ever gone through the theater? In some theater, I mean, if you see, there's a cartoon that comes down. In classic movies, you might see some came from this side, closing, some came from this side, closing. Right? So the cartoon coming down actually is kind of like that. So yes, suspected amaurosis focus actually. So past medical history of these particular things, very major diseases on examination, bilateral carotid break. Ultrasound duplex shows carotid bilateral swing 40% on the right, 70% on the left. What is your suspect actually? The person is probably having carotid stenosis actually. Amaurosis fugax is the presentation, but underlying main condition is what? Main condition is a carotid stenosis. Clear everyone? Amaurosis fugax is the presentation. That's why sudden transient loss of vision. And underlying is the carotid stenosis and future chance of stroke, right? Did I mention that one earlier? Amaurosis fugax means is a future chance of stroke. So we cannot let it be like that. Right? Yes. And how practical is that? I saw it with my grandfather. Like he did have the stenosis. He used to have the vertigo things, and uh, later on, actually, he had a stroke. Actually, even though he did never had the amaurosis fugax, but stenosis was there actually. All right. So basically, what happened? Because maybe smoking, food intake, all these things, hyperlipidemia process never stops. Agreed? So the lipid this came across an atherosclerosis process happens. That is one of the reasons. Whenever possible from your life, you start trying limit those lipid type of food. Actually, extreme fatty food, try avoid always. It's always these are irreversible. Okay, and your carotid will be affected. Some will be denying this thing by telling that then why we came to this world. Okay, I mean, if we can't eat properly, so why we are here actually? No, so that can be a different thing actually. Yes. All right. So eventually leads to carotid stenosis because of all these things. And if there is a carotid stenosis, the procedure you need probably is a endarterectomy. So either you observe or either you go for a carotid endarterectomy, either you go for a drug like a statin to reduce the risk actually. Clear everyone? What are the points they will give you? Either they will reassure or observe aspirin, statin, or carotid endarterectomy. These will be often given option in the question. We'll see a question, it will be clear to you. Don't worry. It's my guarantee. So see this picture, this doctor is anxious, eventually thinking it can be a stroke actually. Anyways, now what are the symptom of carotid stenosis? Symptom transient ischemic attack. They can have a stroke. They can have amaurosis fugax, cerebral infarction. Okay, and they can also have carotid bruit. If you put the stetho, you might hear some bruit. Okay, so these are the things. And if you do fundoscopy, this that it's a possibility. You can also find amaurosis fugax finding or any retinal findings. Okay, so carotid stenosis, moderate, mild, moderate, severe. Clear everyone? So in these cases, mild, moderate, severe. All right. Please check out the percentage again before we go to the question. You have 30 seconds. Okay, let's move forward to the question. 74-year man presents with one episode of right arm and hand weakness. So focal deficit. This is resolve in approximately 1 hour. Her symptoms started while she was gardening. Okay, classic history. Her past medical history are this. All major histories are present. Hypertension, hyperlipidemia. Her current medication includes. Please check out the medications. Examination reveal left-sided carotid. You put the stetho, you will understand there's a bruit going on. Ultrasound Doppler of the carotid arteries demonstrate right or left carotid stenosis, like right 35 and left is 50 respectively. Which one of the following is the left step in the management? You have 30 seconds to think and answer smartly. You can see some answering 3, some answering 4, some also answering 1. Okay, just go with the final answer. Now what is the final answer? Is here. The patient presenting with a transient ischemic attack. According to chat scoring, is transient ischemic attack is it a point for chats? Please do remember TIA, stroke, and all these things. Is this a point for chat? 1 point for chat. Answer is a yes. So if that is present, is it mandatory to start the aspirin? Answer is a yes. So because of the TIA, this is a tricky question actually. I think many got bamboo here.
Yeah. So it's okay. No problem. So characteristicity linked to the nuclear sequence of TIA. Case less than 50. Best next step management. Aspirin here actually. Okay. Indication of carotid endarterectomy includes if like a it has to be a little more actually 70 or more than 70. It has to be a lot of calculations actually out there actually. Okay, so is it clear about the carotid endarterectomy, guys? Is it clear about the carotid endarterectomy? Yes. All right. The person do have chat score, and the chat score, if you do with that one, there's a scoring. You definitely can introduce the scoring. You definitely can introduce the aspirin because score is one or two, one at least. So you like to go with the aspirin here. Okay. Most people will think 4 as observation because it does not up to the level of the thing actually. If you have a diplomatic things like with percentage, we have inquiries on. Feel free to ask actually there actually. We do have inquiries on. If you have any question about percentage of cardiac endarterectomy hypothetical things, feel free to ask us there actually. Alright? Let's not hamper the main stem in the class. Are we clear with the symptoms? So our first priority to see a scenario, pathophysiology, what are the options often given, and we like to do a carotid Doppler. When you do the Doppler, you can see the stenosis. Any of your elderly family member are having vertigo issues, check out the antihypertensive drugs, this that. Do a alter monitoring. If necessary, do a carotid Doppler as well actually for them. Something will be ruled out for sure. Observation is not appropriate. Is less than 60%. We should start the antiplatelet therapy. Yes. Okay. Great. Good job, guys. Just do a little bit more practice. You will be almost there with that one. With that note, our last segment of today's is coming up. Are you happy about it? That things are gonna be finished now? Please make sure don't forget to see our notes. Pituitary we discussed last day, so pituitary is also included here. Screen is gone for a few seconds to bring out the spinal cord. So please check out the pituitary as well. So are you familiar with the pituitary, guys? Pituitary is very important. I hope you all remember the pituitary. Let me share the screen now so that you can see. I hope you remember this particular slide, right? Which I was trying to teach last day. So in most of the tumor, the pituitary tumors, all you need is a surgery, except for prolactinoma cases, where we start the drug therapies. I teach you about the symptoms and other particular things. And also hyperprolactinemia related, we have also solved a recall, right? If prolactin level less than 4,000, In that case,
it can be drug-induced prolactin level more than 4,000. It can be pituitary tumor.
That was a popular
That was a
thing in
popular thing in the exam. Okay.
Let's not get there.
Let's not get there, but it's a part of the neuro syllabus as well.
All good, clear, guys?
All good, clear, guys?
Okay.
Okay.
Let's move and check.
Let's move and check with the spinal cord actually. I don't take much time. Try to be gentle as much as possible. I promise I won't make it complicated actually. I usually try to make things as easy as possible. So try get maximum actually, you know. Yeah. All right. Now, from a spinal cord, you know about spinal cord. So from a spinal cord, what to learn actually? You know? So most easy thing would be where it starts, where it ends, especially about the track, and what type of sensation it is carrying. Clear? Where it starts, where it ends, what type of sensation it is carrying. What are some of the ascending tracks? What are some of the descending? Some tracks are from the up going down, some are coming from down going to the up. This is the basic. Is it clear, everyone? So any track cases, it is very important to learn where the track starts, where it ends, what type of sensation it is carrying, where it is also crossing. All right. Now let's get into the thing. There's certain things as per neuroanatomy is given. It's up to you if you want to go with it. This is a nice to know thing. Different parts of the brain. For MC, you don't need that. Yeah, there's that spinal cord. Some of the segments is that. Please mention nerve root is a part of the orthopedics, so we're not putting into the C1 to C5, L1 to L4, L5, and S1. That's part of the ortho. Okay. Here's some spinal cord features. I'm sure most of you have heard this information before. Continuation of medulla oblongata, then the spinal cord with the vertebral canal, upper boron. So anyways, nothing much here. So here is the thing about the track. Basically, you need to learn few of this thing, and lastly, I'll show you a picture of the different section of the spinal cord to wrap up the glass. Okay. So coming to this particular one, these three track you need to learn mostly. Lateral spinothalamic tract, dorsal column tract, and corticospinal tract. Okay. This one you can understand. This is a motor track and this is a ascending track. Or is it a descending track? What do you think? Cortico-spinal, from cortex coming down to the spine. So it is from up, it is coming down. So this is a descending track. Also this is a motor track. So you're getting an idea what kind of track is this. Next, dorsal column tract, or it is like a posterior column tract. This is taking some of the sensation like position, vibration. Okay. Quick question. Is this an ascending tract? Is it a descending tract? They take sensation and they come to the brain. So this is the ascending tract. Okay, this is a posterior column tract. Carrying the sensation. Last but not the least, spinothalamic tract. Spinothalamic tract taking pain and sensation. Those are not present, my dear. Spinal cord related things are not present in John Mortag. Okay. Next. Here is the thing. Okay, so spinothalamic tract is also carrying the sensation of patella, right? Means pain temperature, lateral spinothalamic tract. Pain temperature, lateral spinothalamic tract. So are we clear which are the ascending tracts and descending tracts first of all? Are we clear with that? Okay, good. Let's get in some lateral spinothalamic tract, corticospinal tract, posterior column tract. This is the anterior part. Here's another picture. So this is anterior part, posterior part, lateral part. Lateral is pythalamic tract, corticospinal tract, posterior column tract. The side. There are more tracks, but we just made that 3 tracks to remember. So about corticospinal tract, what to remember? What type of track is this? Now you need to answer, guys. What type of track is this? Ascending or descending? Quick thing. Is it ascending or descending? It's going down. It is a descending track. Where did it start at? Corticospinal. It started in the cortex. Cerebral cortex. Okay. Premotor area. It's like, cortex, premotor area. It started. Where it ends. What do you think? What do you think? So started in the cortex and ends in the spinal cord. Okay, whatever sensation it carries. Motor sensations. Right. Corticospinal, mainly the all movement, the motor. Where it crossed. Now this is important. For that I have to show you a picture. But do you know this information? Where it crossed? It crossed in the lower medulla. Which, yeah. That's the thing in the pyramid. It's the crossed in the lower medulla. Now, if you see, it crossed into the lower medulla. This picture is even more clear. Even though this is a 3D, but this is more clear. Started and then crossed in the brainstem, in the lower medulla. This is the medulla, lower medulla. It crossed. Then it goes to the spinal cord and supplying to the. Clear now, everyone? The crossing area is clear. And structure it is passes through. Now you can see an idea. Midbrain, pons medulla, brainstem, medulla, and all this thing is crosses through. Passes through, and that also crosses here. Holding here for 10 more seconds, giving you time to absorb this one. Are we clear? Are we clear? Cerebral cortex starting, going into the spinal, descending tract, crossing in the lower medulla. Moving. Yeah. Same picture in different cross section, and here you can see the crosses. Yes. Next one. Spinothalamic tract. What type of tract is this? Sensory tract, motor tract. First of all, sensory tract. Second question, ascending tract. Where it started? Dorsal, dorsal root ganglia, or this in the spine, somewhere in the spine, it started. Okay, so you can see that. Where it ends? Where it ends? In the cortex. Okay. Sensory areas. It will end in the sensories. Whatever sensation it carries. Next question. Answer is a patella. Pain, temperature, lateral spinothalamic tract. Where it crosses. Now, is this one crossing in the medulla? Quick question. Is this one crossing in the medulla? As like the previous. Answer is a no. This one crosses in a different area. So this one just entered, and that immediately it crosses. Immediately it crosses. This is one spinothalamic tract. There is another one that comes and also goes up, right? There is two, right? Two spinothalamic tracts actually. Like one comes from this side, another comes from this side. Both crosses in the down area in the spinal cord. So this crossing is in the spinal cord level. Are you clear, guys? This crossing is in the spinal cord level. If there is a tumor in between the crossing, it has a name. Does anyone know that name? In between the crossing of this two track, if there is a tumor, it has a name. It's called syringomyelia. It's called syringomyelia. Okay, just remember that. So bilateral pain and temperature will be affected. Can I say like that? Bilateral pain and temperature will be affected in the body. That's the syringomyelia, often called cape-like distribution. Okay.
carries this sensation. Last but not the least, what type of track is this? Ascending, descending, where it started, where it's end, what type of sensation it carries. Yes. Again, starting from the sensory track, ascending track, started in the spinal, going into the cortex. Whatever sensation is carrying, position, vibration, 2-point discrimination. Position, vibration, 2-point discrimination. Quick question, where it crosses? Does it crosses in the spinal cord level? This is a major question. Does it crosses in the spinal cord level? Not necessary. So you see it goes up, then it goes into the medulla. Okay, so it nearly crosses in the brainstem level. Okay, it crosses in the, you can say thalamus medulla. I mean, mainly it is crosses in the brainstem level, not in the spinal cord level. You understand the difference between spinothalamic and the this track? Both are sensory track, but the crossing level is different. Okay. Clear about the tracks, guys. So many pictures, this, that, track, upper motor and lower motor. The differences already mentioned, but you can have a look one time. And you will find another one as a brown sequence. If there's a hemisection of the spinal cord, okay, all the things would be ipsilateral. Only one thing would be contralateral. Which thing can be contralateral? Previously we have seen which one sensation can be contralateral. The one that is crosses below, which is the spinothalamic tract, the pain temperature. Okay, isn't it more like a math? Some of the neuro things, yes. Okay, so one math we put into in another actually. So contralateral again, spinothalamic tract. Well done, guys. Now our last slide today is actually knowing about this particular diseases. Okay. Some of you know polio. Can I say polio as a lower motor neuron lesion? Of course we do. Tapes dorsalis has a posterior column that is affected. Amyotrophic lateral sclerosis, all track can be affected, right? I mean motor, sensory, you know, as a upper motor, lower motor, all. Syringomyelia, hemisection. Now coming to this one, let's see the picture. You see the anterior horn of the spinal cord affected. Anterior horn of the spinal cord affected. Okay, so this is related to lower motor. Did I mention that anterior hornsel of the spinal cord is related to lower motor? Today in the beginning I mentioned, last day in the end I mentioned as well. That anterior hornsel of the spinal cord is part of lower motor. So if both anterior hornsel of the spinal cord affected, this is upper motor or lower motor. This is of course lower motor. So all the features of lower motor palsy, flaccid, atrophy, fasciculation, less tone, all part of this thing. Clear now? Everyone clear? All good. Next one is checking. Next one is a tapes dorsalis. Did I mention about the syphilis last day? Did I draw about this thing? That posterior column would be affected. Posterior column carries, you know, position and vibration sense, and the position vibration sense would be affected in syphilis or tapes dorsalis. Clear now? So late stage of the syphilis, this one would be affected. Neurosyphilis. Well done. Next one, amyotrophic lateral sclerosis. You see, some are present in the sensory area, some in the motor area, here and there, mixed up. I mentioned about the mixed up things. That is the motor neuron disease or amyotrophic lateral sclerosis. Are you getting the ideas now? Like, can you make correlation with the neuro? It's very difficult to make correlation with the neuros. Alright. So motor area, sensory area, all affected by amyotrophic lateral sclerosis. Spinal cord also has blood supply. You must be thinking silly question, right? Yes, definitely. Everywhere there is a, we do have a blood supply. The spinal cord has a anterior spinal artery and posterior spinal artery. So if your whole anterior spinal artery is affected, okay, you see all the tracks are affected except for which one? all the tracks are affected except for posterior column tracks actually. Okay, clear now what kind of feature you will get. So your position and vibration sense will be intact. Otherwise everything will be affected. Okay. Next coming is a vitamin D related deficiency, subaqueous combined degeneration. This has again similar kind of thing, some sensory and other relevant. So mostly sensory. This is a sensory tract. This is also sensory tract. Subaqueous combined degeneration. Okay, heard this name before. I'm pretty sure it's MBBS topic too. Yes, I mean vitamin D deficiency, subaqueous combined degeneration. This is the tract area that is affected. Both are the sensory tracts. Last but not the least, syringomyelia. Just now I mentioned. In between the crossing of two spinal cord, isn't it? In between the crossing, it's in the middle. It's in the crossing of the both tracks. Right? So it's like a syringe. It's like a cape-like distribution, like a pain and temperature lost in the both areas. Okay. Bilateral spinal thalamic tract involvement. Where is the crossing in the spinal cord level? Where is the lesion? Last but not the least, hemisection already we mentioned. All would be ipsilateral, only one would be bilateral. Which one? Sorry, one would be ipsilateral, one would be only contralateral. Which one is contralateral? The spinothalamic tract. Only pain temperature is spinothalamic tract. Okay, I hope that's clear to all of you. Again, all the summary is also given in one page. Have a look on that one. Okay, but so far whatever I have mentioned, if you remember that, that will be more than enough. Okay, so I guess we are done here for today. Looks like if there is anything will come up, we do have a recall class and I can clarify more things. Yes, and good luck. And inquiry zone is made. If you have anything that came up during the class which you didn't get the answer, feel free to ask me in the live class, the inquiry zone. I'll get back to you there actually, Alright, so good luck and try write your inquiry, guys. Please make sure you don't. Yeah, so that's the thing. Yeah. Handbook page is already mentioned, I think, in the beginning, I think, earlier. Maybe you missed first class, my dear. Okay, but let me clarify one more time. Yes, this one is the handbook one. Good, clear. Thank you, and take care. This is the finishing of the Neurology Theory 02.